acute pulmonary edema, this is a very bad picture, as you can see. They would require immediate synchronized direct current DC cardioversion due to a risk of rapid clinical deterioration. Oh, by the way, whenever you have cardioversion, it's usually always direct current DC cardioversion. But the trick here is to know which one is synchronized and which one's unsynchronized. And usually synchronized is when they're hemodynamically stable, or if it's an atrial problem, or here in a supraventricular tachycardia. But if it's a ventricular tachycardia, or if it's a patient who is unstable with a ventricular tachycardia, then you do unsynchronized. So here we're talking about supraventricular tachycardia, and that would require immediate synchronized direct current, or DC cardioversion, and that's due to a risk of rapid clinical deterioration. So it involves delivery of low energy electrical shock that's synchronized to the QRS complex, and if possible it could provide adequate sedation and analgesia prior to cardioversion, because it's kind of painful to just throw electricity into somebody's chest. It seems kind of painful. So yeah, you'd want to sedate them and give them analgesia properly before performing this. And since it's unsynchronized, it's something that you can do with time to adjust all the levels on the machine and have the patient adequately sedated and given proper anesthesia. Unsynchronized cardioversion is given when you have ventricular fibrillation, like we said, when you have pulseless ventricular tachycardia or pulseless cardiac arrest. In paroxysmal supraventricular tachycardia, again, remember it's the narrow QRS complex happening with less than 120 milliseconds, and the rate is going to be over 160. So it's just a lot of spikes, a lot of QRS spikes. That's paroxysmal supraventricular tachycardia. Next is atrial flutter. That's the most common cause. The most common cause of atrial flutter is going to be a re-entry circuit around the tricuspid annulus with slowing of the impulse through a region known as the cavo-tricuspid isthmus. I don't know if they might ask that, but it's atrial flutter. It's usually due to a tricuspid annulus re-entry circuit. All right, and it's a rapid sawtooth pattern. The flutter waves are going to be characteristic on EKG, and that's a flutter. So it's like a sawtooth, like a saw. Next is sinus tachycardia. So sinus tachycardia, the P waves are usually going to be seen before the QRS complexes. It's a ventricular rate is going to be more than 100 beats per minute. P waves are usually upright and leads 1 to AVF and V3 to V6. And there's maximal heart rate in sinus tachycardia. It can be determined between beats per minute is going to equal the 220 minus the age. All right, so what are some of the approaches to sinus bradycardia? Okay, so you would want to check the pulse if it's less than 50 beats per minute, or if they're symptomatic like dizziness. That would be indication for bradycardia. You want to assess appropriateness for clinical conditions, and then you also want to identify and treat underlying causes. IV access is also used with cardiac monitoring, and that's used to identify the rhythm. Pulse oximetry with oxygen and for the hypoxemia, and you'd also want to administer a 12-lead EKG if possible, but you don't want to delay the therapy. So if you have persistent bradyarrhythmias and one of the following, either hypotension or signs of shock, acute mental status changes, chest discomfort concerning for cardiac ischemia, or an acute heart failure, if you don't have any of those, you just monitor them and observe them. But if you do have signs of hypotension, shock, mental status changes, chest discomfort, acute heart failure. Then you want to give IV atropine, and you want to repeat the IV atropine every 3 to 5 minutes up to until you get it to 3 milligrams maximum, and every dosage is 0.5 milligrams. So again, they're not going to ask you dosages, so it's just IV atropine, and repeat that until you get to maximum dosage. But if still you have no response, then you want to do transcutaneous pacing, or you can do IV dopamine or IV epinephrine. And if you still are not having any type of response at that point, you want to consider consulting for transvenous pacing. Okay, so remember that first you want to do atropine. If that doesn't work, you want to give them IV dopamine, and if that doesn't work, you want to give them epinephrine, and if nothing works, transvenous pacing. So a normal heart rate is between 60 to 100 beats per minute. Sinus bradycardia is a heart rate that's less than 60 beats per minute, and it has a regular rhythm and a constant PR interval. It can occur normally in adolescents and in young adults, and it's in well-conditioned athletes, as well as some elderlies, especially during sleep. So those are all normal conditions: adolescents, young adults. The well-conditioned athlete is going to be a common one. Pathological causes of bradycardia would be sinus sick syndrome, an MI or an ischemia, hypothyroidism, increases in intracranial pressure, and medications. And symptoms for bradycardia are usually asymptomatic, but some people develop fatigue, dizziness, lightheadedness. There could be hypotension, syncope, angina, or CHF. And norepinephrine is going to be indicated to treat severe hypotension and shock, but not bradyarrhythmias. Okay, so remember that in a sinus bradycardia, the heart rate is going to be less than 60 beats a minute. The rhythm is regular. P waves are present, and they're seen before each and every QRS complex, and they're identical. The PR interval is normal, so it's a 0.12 to 0.20 duration, and the QRS complexes are also normal within 0.120, and the shape is also normal. So this is just a normal beat. It's just a normal EKG. It's just it's just a slowdown of the conduction. So EKG interpretations: a heart rate is going to equal the number of the R to R intervals within 6 seconds, and you multiply that times 10. For an irregular rhythm, you want to count the R to R intervals for a full 60 seconds first. So for a full minute, you want to check that R to R interval for a more accurate result. And then you also want to measure R to R intervals to determine regularity. Are they happening continuously or not? You also want to evaluate the P waves. You want to ask yourself, are P waves present? Is there a P wave before every QRS complex? Are the P waves looking the same? Are they identical? You want to measure and evaluate that PR interval, and then you also want to measure the QRS complex and examine it for any type of changes in amplitude or voltage. And that's how you interpret an EKG, by the way. Next is going to be an approach to wide complex tachycardia. So in a wide complex tachycardia, you want to ask yourself, is there any type of AV dissociation, or are there any fusion or capture beats? If not, then you want to consider supraventricular tachycardia. And if they're stable, then you want to just do vagal maneuvers to determine the rhythm, and carotid massage, rate control, and then treat that accordingly. However, if they do have AV dissociation with fusion with a wide complex tachycardia, then that's basically the diagnosis of a ventricular tachycardia. Next, you want to find out if that ventricular tachycardia is going to be stable or unstable. If it's stable, you just give them IV amiodarone for that wide complex tachycardia. But if they're unstable, meaning they have hypotension or altered mental statuses or respiratory distress, then you have to do synchronized cardioversion. And now, monomorphic ventricular tachycardia means that the QRS complexes are very wide, but they all match each other. The fusion beats are basically captures of electrical signals through both the atrium and the ventricle, and that happens briefly, it's caused by a hybrid of normal and wide QRS complexes, and the P waves are going to precede the fusion complex. So if you see an EKG, that fusion beat is going to be like an S wave. It's going to look like an S wave, where there's going to be like an ST wave depression kind of, but the S wave is going to be very prominent, and before that particular QRS complex there's going to be a P wave. So that would be a fusion beat, and if you see that, that's a wide complex tachycardia or ventricular tachycardia. So a sustained wide complex tachycardia with a fusion beat is a sustained monomorphic ventricular tachycardia. And in the presence of an AV dissociation, it's also the diagnosis of a ventricular tachycardia. The sustained monomorphic ventricular tachycardia occurs very early on, within 6 to 48 hours during an MI, and it's associated with increased risks of in-hospital mortality. And among all the antiarrhythmics that can be used for this condition, there's drugs like amiodarone that can be used, lidocaine can be used, procainamide, IV amiodarone, however, that's the preferred one. So if you see sustained monomorphic ventricular tachycardia and they're asking you what would you treat this patient with, if they're stable, it's going to be amiodarone. So then amiodarone and lidocaine, that's often used in the treatment with hemodynamically stable patients with wide QRS complexes. Amiodarone is going to be used in the treatment of atrial fibrillation as well, but not paroxysmal supraventricular tachycardia. Remember that. So amiodarone, again, that's for atrial fibrillation and for ventricular tachycardia, but not paroxysmal supraventricular tachycardia. Okay, sick sinus syndrome is an impaired SA node. The sick sinus is that the SA node is sick. There's loss of automaticity because of fibrosis, or there could be a degeneration of the SA node, and that surrounds the myocardium. They present with fatigue, lightheadedness, palpitations, pre-syncope or syncope. And on EKG, they can have bradycardia or sinus pauses or arrests. That's what's going to give them their palpitation-like symptoms. There's going to be an SA node block or alternating bradycardia and atrial tachyarrhythmias, and that's called tachyarrhythmia bradyarrhythmia syndrome. Okay, so next one would be Wolff-Parkinson-White syndrome. And Wolff-Parkinson-White is an accessory pathway defect, and that conducts a depolarization directly from the atria to the ventricle without hitting that AV node. So the atrial fibrillation is going to occur with Wolff-Parkinson-White in about 10 to 30% of individuals, and potentially that's going to be life-threatening in patients. Atrial fibrillation in Wolff-Parkinson-White patients can bypass the usual rate-limiting function that the AV node does. So because it bypasses it, it can lead to a rapid ventricular response rate. And persistent atrial fibrillation with rapid ventricular response can ultimately deteriorate into ventricular fibrillation. So that's not good. So atrial fibrillation can lead to a ventricular fibrillation because it's just hopping over that AV node. It's just going from one area, the atria, to the ventricles, and that's seen in Wolff-Parkinson-White syndrome. That's ultimately the worst prognosis of it. So acute treatment is going to be to very rapidly control that ventricular response and to try to stop the atrial fibrillation. And you do this in stable patients by rhythm control and antiarrhythmic drugs like IV ibutylide or procainamide. And procainamide not only is preferred, but that's the one that they're going to ask you on the exam. So Wolff-Parkinson-White is going to be treated with procainamide if they're stable. However, if they're hemodynamically unstable, remember you want to do immediate electrical cardioversion. Contraindications to AV blocking agents such as adenosine beta blockers, calcium channel blockers, verapamil, and digoxin. So those cannot be given with Wolff-Parkinson-White because those can promote actual conductions across accessory pathways and degeneration of the atrial fibrillation and converting that atrial fibrillation into VFib. So you wouldn't want that. So because you're blocking the AV node with adenosine beta blockers, calcium channel blockers, verapamil, or digoxin, since that blocks the AV node to begin with, and on top of that you have Wolff-Parkinson-White, which is known to jump over the AV node, you're kind of eliminating that AV node. You're just making a very easy bridge for that atrial fibrillation to just go into the ventricles and cause ventricular fibrillation. So that's why beta blockers, adenosine, calcium channel blockers, verapamil, and digoxin are contraindicated in Wolff-Parkinson-White. And remember, Wolff-Parkinson-White, obviously, they're going to give you an EKG, and that EKG is going to give you the delta wave, which is that triangular shape between the P wave and the R wave. And that's called the delta wave. The PR interval here is going to be less than 0.12 seconds, and because it has a little triangular pattern, you're actually widening that QRS complex, so the QRS complex will be a little bit wide. So it'll just show up, it'll look like a normal EKG, except the base of the QRS, or the midline of the QRS, is going to be wider than normal. And if you see that, I mean, sometimes you don't even have to read the vignette. That's basically Wolff-Parkinson-White. Just go and look down and see if you have any kind of answer choice that matches that EKG to Wolff-Parkinson-White. It could be the drug procainamide, or it could be what medication do you want to avoid, so beta blockers, calcium channel blockers, and so on. So, or it can ask you what do you ultimately want to prevent, and it would be ventricular fibrillation. Next up is going to be long QT syndrome. So in long QT syndrome, this could be either acquired or inherited. In the acquired long QT syndrome, this can be either caused by electrolyte problems like hypocalcemia, hypocalcemia, hypomagnesemia. So electrolytes are low. And then it can also be caused by medications such as macrolide antibiotics can cause long QT syndrome. Fluoroquinolones can cause it. And the Q in quinolone, QT syndrome, that's a good one. Psychotropic medications like antipsychotics, tricyclic antidepressants, SSRIs, opioids such as methadone and oxycodone can cause long QT syndrome, as well as antiemetics like ondansetron and granisterone, or granistrone, ondansetron is the only one that I remember. Antiarrhythmics like quinidine, procainamide, flecainide, amiodarone, and sotalol. These can all cause QT syndrome prolongation. Inherited causes of long QT syndrome, or a prolonged QT, is going to be something called Jervell-Lange-Nielsen syndrome, and that's autosomal recessive. So because it's autosomal recessive, you're going to see it later on in life, and it's going to be less, have less complications than the autosomal dominant version, which is called Romano-Ward syndrome. So remember, Jervell-Lange-Nielsen syndrome, autosomal recessive. Romano-Ward is going to be autosomal dominant. So the QT interval is going to be a depolarization and repolarization of the ventricles. That's how you get the QT interval. And a normal duration is variable, but it's usually less than 440 milliseconds in males and less than 460 milliseconds in females. We were talking about Jervell-Lange-Nielsen syndrome, which is the autosomal recessive form, and this is a family history of sudden death. They'll present with congenital sensorineural hearing loss in the history, and obviously a long QT that's going to be around 600 milliseconds. There's high risks of syncope. There could be life-threatening ventricular arrhythmias like torsades and sudden death, because remember, will eventually lead to sudden death. Okay, so also, how would you treat Jarval-Nielsen syndrome is to refrain from vigorous exercise because it does cause sudden death, avoid medications that prolong the QT intervals, maintain normal levels of calcium, magnesium, and potassium, as well as to give them pharmacotherapy. You can also do beta blockers, which are class 2 antiarrhythmics, but remember, except sotalol. Sotalol causes QT elevation. And blunting of exertional heart rates and shortening of the QT interval and is the class of choice. So beta blockers are good. Symptomatic patients like lightheadedness or palpitations, or those with histories of syncope that require beta blockers plus long-term pacemaker placement. Now, causes of acquired long QT syndrome, we already went over this, but medications like diuretics due to electrolyte imbalances, antiemetics like ondansetron, antipsychotics like haloperidol, quetiapine, risperidone can cause long QT syndrome. TCAs, SSRIs like citalopram, antiarrhythmics like amiodarone, sotalol, flecainide, anti-anginal drugs such as ranolazine, anti-infective drugs like macrolides or fluoroquinolones, and antifungals as well can cause long QT syndrome. Metabolic disorders, obviously you have your electrolyte imbalances, like we said, hypokalemia, low magnesium, low calcium, the starvation state where you're not having the electrolytes that you need, and also hypothyroidism. Bradyarrhythmias like sinus node dysfunction and AV block, second or third degree AV block, can lead to long QT syndrome. That's why it's so important to fix that second degree AV block, because it could lead to ventricular fibrillation due to long QT syndrome. And other causes of long QT syndrome would be like hypothermia, myocardial ischemia or infarction, intracranial diseases, and HIV infections. So what's Torsades de Pointes? So palpitations with pre-syncope, syncope can also resolve spontaneously, or they can degenerate into ventricular fibrillation and sudden death. You want to treat Torsades de Pointes immediately with defibrillation in hemodynamically unstable patients. And you want to give IV magnesium sulfate. That's first line for Torsades de Pointes, and that's for conscious or stable patients. Even if the magnesium levels are normal, you want to still give them IV magnesium, followed by the identification or removal or the correction of the offending cause. If the cause of Torsades de Pointes is quinidine, then you want to treat with sodium bicarbonate. Sodium bicarbonate is also used for cardiac arrest due to metabolic acidosis, hyperkalemia, or a TCA overdose. And remember that Torsades de Pointes on the EKG is going to be, there's going to be a long QT interval, and there's going to be twisting or an undulating pattern within the QT segment. Okay, next would be cardiac arrest, and how would you approach an adult in cardiac arrest. So if you see an adult in cardiac arrest, the first thing you want to do is obviously CPR. You want to give them oxygen and attach a monitor or defibrillator to them. Then you want to check if you want to check the EKG if they're under ventricular fibrillation or a pulseless ventricular tachycardia, or if they're asystole. So if they have ventricular fibrillation or pulseless ventricular tachycardia, then you want to see if they're in shock. If they're in shock, most likely you want to give them CPR for 2 minutes, or every 2 minutes you want to give them CPR, and you also want to obtain IV access at that point. Because if they're in shock, you want to ask yourself, is the rhythm shockable? Can you actually do cardioversion on them? If not, you want to do CPR every 2 minutes, and you want to treat any type of reversible causes that could have caused the cardiac arrest. If they are shockable, then you want to shock, and you want to continue CPR again for every 2 minutes. You want to give them epinephrine every 3 to 5 minutes, and you possibly want to advance their airway if they're having signs of respiratory distress. At that point, again, if they have a shockable rhythm, then you want to shock them again, give them CPR every 2 minutes, and at that point, you don't want to give epinephrine, you want to give amiodarone and treat any kind of reversible causes. If they're not shockable, you want to go back and do CPR every 2 minutes. Again, make sure they have that IV access and give epinephrine every 3 to 5 minutes. And possibly you want to keep checking that airway to see if they need advancement in the airway. And that's how you do it. If they respond to shock, then you want to give amiodarone and treat the reversible causes. If they don't respond to shock, you want to just continue giving CPR every 2 minutes and epinephrine every 3 to 5 minutes and checking their airway. Pulseless electrical activity. This presents with an organized rhythm on cardiac monitor, and they're going to have palpable pulses in cardiac arrest patients. So their carotids are palpable. CPR is then given with vasopressors like IV epinephrine or single-dose vasopressin, and that maintains adequate coronary and cerebral perfusion. That's why you do the vasopressors, is to maintain perfusion to the brain and to the heart. The CPR is then done, and it should be continued while the attempts are made to identify and treat any type of reversible causes of pulseless electrical activity. And then next would be ventricular fibrillation and a sustained ventricular tachycardia, and that would be the feared complication after an MI. There can have electrolyte imbalances, myocarditis, cardiomyopathy, drug side effects, and the ACLS algorithm for ventricular fibrillation and pulseless ventricular tachycardia as well stresses the importance of early defibrillation. Energy required may be around 200 to 360 joules. So that's going to be your shockable joules, 200 to 360. And there's the greater the time of onset of the ventricular fibrillation and the use of the effective CPR, rhythm analysis and early defibrillator is going to be required lower, and that lowers the survival. In witnessed arrest, less than 5 minutes, defibrillation should be performed immediately. If there's unwitnessed or witnessed arrest that lasts more than 5 minutes before the arrival of the defibrillator, then a cycle of CPR should precede the defibrillation. And studies in sudden cardiac arrest have shown better outcomes and improved survival to discharge with compression of only CPR than standard CPR prior to arrival to the emergency personnel. So yeah, you'd want to just do that algorithm, which is want to see if they're shockable, shock them, give them IV access. If it's shockable again, you want to shock them, CPR every 2 minutes, epinephrine every 3 to 5 minutes. If they have, again, another shockable rhythm, you want to shock, and then CPR every 2 minutes, but then you give amiodarone. If they don't have a shockable rhythm, you're going to go back, continue CPR every 2 minutes, and give epinephrine. So that's the main thing, is CPR every 2 minutes. CPR every 2 minutes. All right, so reversible causes of asystole and pulseless electrical activity. So the 5 H's and the 5 T's. So the 5 H's are going to be hypovolemia, hypoxia, hydrogen ions or acidosis, hypo or hyperkalemia, and hypothermia. So those are your 5 H's of causes of asystole. Now the 5 T's are going to be tension pneumothorax, cardiac tamponade, toxins like narcotics or benzodiazepines, thrombosis like pulmonary or coronary artery thrombosis, and trauma. There's no role of synchronized cardioversion and defibrillation in pulseless electrical activity or in asystole. So synchronized cardioversion is going to deliver a synchronized shock to that QRS complex, and it's used in symptomatic or sustained monomorphic ventricular tachycardia that can be unresponsive to antiarrhythmics. And then in hemodynamically unstable atrial fibrillation with a rapid ventricular response, you can give them a synchronized cardioversion. Defibrillation delivers energy randomly during cardiac cycles without synchronization to the QRS complex needed for pulseless ventricular tachycardia and ventricular fibrillation. The way I like to remember it is that if it's in the atria, if your problem's in the atria or you have supraventricular tachycardia and they're unstable, you do synchronized cardioversion. If it's in the ventricles, like ventricular fibrillation, then with a patient that's hemodynamically unstable, then you do unsynchronized cardioversion. Sorry, and that's just something that the guideline that I've used on test questions, and it seems to always work. So factors associated with poor outcomes after witnessed out of hospital sudden cardiac arrest would be the time elapsed prior to effective resuscitation or delayed bystander CPR, also delayed defibrillation. So the following are going to be associated with poor outcomes after there's a witnessed cardiac arrest that happens outside of the hospital. So the time elapsed prior to effective resuscitation or delayed bystander CPR, if it takes too long for a bystander to start administering CPR, or if there's any type of delay in defibrillation, that's a poor outcome. Initial rhythm and pulseless activity or asystole is a poor outcome. A prolonged CPR, so if it takes too long to get CPR done, meaning more than 5 minutes, that's a poor outcome. Absence of vital signs, obviously, advanced in age, prior history of cardiac disease, more than 2 chronic illnesses. If they have persistent coma after a CPR, that's not a good outcome. If they need to be intubated or given vasopressors, at that point you're just trying all your might to save their life, and that's not a good outcome. Pneumonia or renal failure after CPR, if they get any of that, that's a bad outcome. Sepsis, cerebrovascular accidents, or any type of heart failure that's a class 3 or class 4 heart failure, that's a poor outcome. Well, these already sound like really bad things to begin with, and then you just add that to cardiac arrest patients, and that's not a good combination, unfortunately. So next is central venous catheters, and these are commonly used in patients with difficulty in vascular accesses for long-term administration of medication. So like we said earlier, one of the things that you do if they're hemodynamically, or not hemodynamically stable, but if they have ventricular fibrillation or asystole, you want to give them IV access on top of doing the CPR and all that, because you want to eventually sooner than later, start giving them medications and fluids. So you need that central venous catheter. Complications occur in 1 to 5% of cases and include atrial puncture or arterial puncture. A pneumothorax can happen, hemothorax, thromboses, air embolisms, sepsis, vascular perforations, and myocardial perforations that lead to tamponade. Those are some of the complications of a central venous catheter. A chest X-ray should be obtained to confirm proper placement of a catheter and absence of complications. You don't just want to insert that central venous catheter and just, wipe your hands and leave. You kind of want to make sure that you placed it in the correct area and there's no complications that can arise from that placement. And a way to avoid perforation is that the catheter tip should be located proximal to either cardiac silhouette on the X-ray or the angle between the trachea and the right mainstem bronchus. Ideally, the catheter tip should lie in the superior vena cava. So the tip placement is going to be in smaller vessels. Those can cause perforations, obviously. So pulmonary hypertension is our next topic, and this is defined as a mean pulmonary arterial pressure of more than 25 millimeters of mercury at rest. because normally it should be less than 20. So if it's more than 25, that's pulmonary hypertension. So what is the WHO classification? A WHO? The WHO, World Health Organization classification of pulmonary hypertension, and that's divided into 5 groups. Group 1 is due to idiopathic causes, and at that point you want to treat with endothelin receptor blockers like bosentan or a PDE5, prostaglandin E5 inhibitors like sildenafil, or prostaglandins like epoprostenol. Group 2 pulmonary hypertension classifications, those are due to heart diseases. So in this case, pulmonary hypertension with heart disease should be treated with loop diuretics or ACE inhibitors, ARBs, and often in combination with a beta blocker, and in some cases you want to give them aldosterone blockers. In Group 3, Group 3s are due to chronic lung diseases, so COPD, chronic hypoxemia, like that. You want to treat with oxygen, or you can give them bronchodilators. Group 4 of the WHO classification for pulmonary hypertension are due to thrombotic occlusions of the pulmonary vasculature. So treatment there would be long-term anticoagulation due to chronic thromboembolic occlusion. And then finally, Group 5 is going to be due to hematological disorders like myeloproliferative disorders, systemic conditions like sarcoidosis, metabolic disorders, glycogen storage diseases, or any type of other miscellaneous causes can give you pulmonary hypertension according to the WHO classification. So you have your Group 1s, 2, 3, 4, and 5. Symptoms of pulmonary hypertension would be dyspnea, fatigue, and weakness. There could be angina on exertion, syncope, and a distension of the abdomen with abdominal pain. Also, signs of pulmonary hypertension would be left parasternal lifts or prominent right ventricular heaves. There can be a jugular venous distension, a loud P2 in the second heart sound. That's the pulmonic component of the pulmonary valve. That'll be loud with pulmonary hypertension because it's backflowing and it's shutting that valve because there's so much tension in there. Pansystolic murmurs or tricuspid regurgitation. Also, there could be a right-sided third heart sound, ascites or peripheral edema, hepatomegaly, and then cool extremities as well, because they're just not getting that blood out. It's just hypertension within the lungs. So in acute dyspnea in hospitalized patients, acute dyspnea, there could be mechanisms of arrhythmias, bronchoconstrictions, congestive heart failure or hypovolemia, infections like pneumonia and aspirations, pleural effusions, pulmonary embolisms, anxiety. All those can cause acute dyspnea in hospitalized patients. So risk factors for arrhythmia. Let's start off with arrhythmias. Cardiac disease can be a risk factor for an arrhythmia, electrolyte abnormalities, and the clinical features of patients with arrhythmia with acute dyspnea would be dyspnea and palpitations, tachycardia, and bradycardia. Okay, so bronchoconstriction can also cause acute dyspnea in a hospitalized patient. Risk factors here for bronchoconstriction would be obviously asthma can cause bronchoconstriction, medications like aspirin and beta blockers. So they'll present with wheezing and prolonged expiration when they'll give you a bronchoconstriction. CHF can give you acute dyspnea, so cardiac diseases, chronic kidney diseases, iatrogenic causes, so if they give you too much liquids, too much fluids, and blood products, that can give you acute dyspnea. As well, and clinical features would be like crackles, elevated JVD, so the elevated jugular venous pressure would be more than 8 centimeters of water, and there can also be lower extremity edema. Other causes of acute dyspnea would be like infection, pneumonia, and aspiration. So infection, pneumonia, or aspiration is due to chronic lung disease. That's a risk factor for that. Immunosuppression, impaired mental status, strokes, or dysphagia. And they will present with probably fever and leukocytosis. Pleural effusion. Those risk factors for pleural effusion would be congestive heart failure, chronic kidney disease, or malignancy. And they're going to present with decrease in breath sounds and dullness to percussion as well, obviously, because of the buildup of fluids. Pulmonary embolism can cause acute dyspnea with prolonged immobility, surgery of the hips, the knee replacement surgeries. Those can all cause acute dyspnea with the pulmonary embolism. So think lower extremities, and they'll present to you with tachycardia, tachypnea, hypoxemia, and then signs of DVTs. And then anxiety can also cause acute dyspnea, and that's due to either dementia or chronic mental illness or sleep deprivation. And they'll have signs of tachycardia, tachypnea, and normal oxygenation to the lung examination. So here they'll have tachypnea, but there's going to be normal examination on lungs, and also normal oxygenation. So aspirin is going to be the most common trigger for bronchoconstriction in patients with asthma, especially those with concurrent chronic rhinitis, as well as nasal polyps. Think aspirin. Cardioselective beta blockers, those are considered safe in patients with mild to moderate asthma, but they can all be triggered with bronchoconstriction at higher dosages and should be used cautiously in asthmatics. There's one called nebivolol, and that's cardioselective, nebivolol. In pleural effusions, there can be a decrease in movement of the ipsilateral chest wall as well. So if the effusion is happening on, let's say, the left lung, that left wall the movement is going to be decreased because the pleural effusion would be on the left, for instance. Okay, next is your thoracic aortic aneurysms. Thoracic aortic aneurysms can give you asymptomatic, or it can cause chest pain, back pain, can give you flank pain or abdominal pain, and that all depends on the location of the aortic aneurysm. Ascending aortic aneurysms, that comes up anywhere from the aortic valve to the innominate arteries, like the brachiocephalic arteries. And the causes of an ascending aortic aneurysms would be either cystic medial degeneration, and that depends on the age, as well as connective tissue diseases like Marfan's or Ehlers-Danlos syndrome. Those are all ascending aortic aneurysm causes. Marfan's, Ehlers-Danlos, or connective tissue diseases. Now, descending aortic aneurysms are distal to left subclavia, and that's due to atherosclerosis, and risk factors would be like hypertension or hypercholesterolemia, as well as smoking. So a chest x-ray in a transabdominal aortic aneurysms or a thoracic aortic aneurysm causes a widened mediastinal silhouette. So a thoracic aortic aneurysm, causes a widened mediastinal silhouette. There's an increase in aortic knob, so that knob on the chest x-ray is going to be big, and there's going to be tracheal deviation as well. So the chest x-ray won't be able to distinguish a thoracic aortic aneurysm from a tortuous aorta because of the knob. You just see it widened. So how would you distinguish that and confirm it? You do that with a CT scan with contrast. Now, abdominal aortic aneurysms, the normal diameter of an aortic aneurysm is between 1 to 3 centimeters, and in a AAA or an abdominal aortic aneurysm, and it's more than 3 centimeters. Unlike a thoracic aortic aneurysm, it doesn't form false lumens, and an intimal flap is composed of going to be 3 layers. So it's usually found incidentally, and it needs close-up follow because of rupture, and that rupture can be life-threatening. So the image modality of choice here would be an abdominal ultrasound, and that's 100% sensitivity and specific, and there's no need for contrast. Also, the abdominal ultrasound is inexpensive, so that's good. And it facilitates measurements of the aneurysm size, and it shows the presence of a thrombus if need be. Screening in men is going to be between the ages of 65 to 75 who have smoked cigarettes or have had greatest benefits from screening. Those are the patients that have the greatest benefits from screening. Or one-time abdominal ultrasound is suggested in patients. That's recommended. Risk factors for developing an abdominal aortic aneurysm would be patients that are older than 60 years of age, obviously cigarette smoking, or a family history of abdominal aortic aneurysm. Remember that family history connection. If they've had it before or if they've had it in the family, they're most likely at risk, and that's going to be the highest risk factor in general. White race, so white people, and atherosclerosis are going to be the ones that are going to be at highest risk for developing abdominal aortic aneurysms. The risks of abdominal aortic aneurysm rupture increases in patients with large aneurysms, more than 5.5, and aortic expansion rates is going to be more than 0.5 centimeters every 6 months to more than 1 centimeter a year. Females also have an increased risk of rupture. Current ongoing smoking, if they're smoking and they have hypertension, that also has an increase in rupture risk. And hypertension has a weak association with AAA formation and expansion and rupture. So you would think hypertension maybe, but actually it doesn't. There's a weak association there. The chances of it rupturing are going to be a very large aneurysm, or the rate of expansion is going to be happening very fast if they're female, if they're currently smoking or they've had smoke, and if they have hypertension. But hypertension alone is a weak association. So never pick hypertension alone as a major risk factor for a AAA. So what if it ruptures? If there's a rupture of an abdominal aortic aneurysm, patients present with profound hypotension. Imagine that is the thickest artery in the body, and it just ruptures, all that volume just left. Profound hypotension. Abdominal or back pain is going to be followed by syncope, and examination it may show pulsatile masses at or above the level of the umbilicus. A AAA can also rupture into the retroperitoneal space and form an aortocaval fistula, and that leads to venous congestion, and it causes fragile and distended veins in the bladder that can rupture, causing gross hematuria. So then the screening and surgical repair is done when the aneurysm is 5.5 centimeters or greater, and that's shown to decrease mortality. And the indications for surgical repair or endovascular repair is when the size is more than 5.5 centimeters, or there's a rapid rate of expansion that's more than 0.5 centimeters within 6 months, and if it's greater than 1 centimeter within a year. Also, if they have presence of symptoms like abdominal pain or back or flank pain, limb ischemia, and that's regardless of the size, then that would be an indication for surgical repair. There's also a risk of AAA formations and expansions in diabetics versus non-diabetics. So look for that too as a risk factor. Then peripheral artery aneurysms in the popliteal artery, that's most commonly found following a femoral aortic aneurysm, and that's located below the inguinal ligament. It compresses adjacent structures like nerves and veins, and can cause thrombosis and ischemia, and that's frequently associated with a AAA. So moving on to the next subject is peripheral artery disease. And clinical features of peripheral artery disease, the etiology is that atherosclerosis is going to be due to risk factors like diabetes or hyperlipidemia or hypertension, if there's a history of smoking, or if they're greater than 70 years of age. Also, the way they present with peripheral artery disease is asymptomatically 20 to 50% of the time, but if there could be physical findings such as a decrease or absent pulse below the level of the stenosis. There can be occasional bruits over the stenotic lesions, poor wound healing in areas of diminished perfusion, also cool extremities and prolonged venous filling time, as well as shiny atrophied skin with nail changes. They like to ask that one. Shiny atrophied skin with nail changes. Also foot pallor with leg elevation. That's your Borger's test. Specific pain patterns would be buttock and hip pain with aortoiliac disease. So if they present to you with buttock or hip pain and they have some type of aortic iliac disease, then that could be a sign of peripheral artery disease. Also, bilateral diminished or absent groin pulses. Occasional bruise over the iliac and femoral arteries are never a good sign. And muscle atrophy and slow wound healing in the legs can be signs of peripheral artery disease. There's one syndrome called Leyrick's syndrome, and that's a triad. So the triad is erectile dysfunction, buttock or hip pain, and absent femoral pulses on examination. That's a good one for peripheral artery disease. Also thigh pain, like we said, the aortoiliac or common femoral diseases. And they'll have normal groin pulses, but the distal pulses are going to be decreased. Also, they can present with calf pain, and that's the most common cause, and that's increasing pain with exertion, and it goes away with rest. The upper 2/3 of the calf is where the superficial femoral artery disease is most likely going to affect. The lower 1/3 of the calf is the popliteal artery disease. And finally, foot pain, there could be either tibial or peroneal artery disease. So the diagnosis for peripheral artery disease is usually done with an ankle brachial index. If that's abnormal, you want to do an atrial or arterial duplex ultrasound, who are being considered for surgery. A supervised graded exercise test is going to be the most useful intervention to improve functional capacities and to reduce the claudication, which includes a minimum of around 12 weeks with 30 to 45 minutes of rest at least 3 times a week. And the goal here is to do a reproduction of the claudication symptoms during each session. I'm sorry, I said at rest, I meant on exercise. 30 to 40 minutes of exercise 3 times a week, and the goal is to actually reproduce the claudication symptoms and the pain during each session. Antiplatelet therapy, like low-dose aspirin, that reduces the risk of coronary artery disease. And other measures for treating peripheral artery disease would be to stop smoking, aggressive diabetes control to get that hemoglobin A1C less than 7%, and blood pressure control with statins, or blood pressure control and statins as a recommendation. There's also a medication called cilostazol, and that should be considered in patients who have persistent symptoms of peripheral artery disease despite any type of antiplatelet therapy and supervised exercise programs. And then finally, there's a treatment called percutaneous surgical revascularization, and that's basically reserved for patients with limb-threatening complications where you don't want it to get to the point that it needs to be amputated. So you do surgical revascularization of the area, and that's significant limitation in activities of daily life. They can't walk, they can't function because of this, or failure to respond to any type of exercise or pharmacological therapy. Surgery is usually always last on the list. So how do you interpret ankle brachial indexes? So the ankle brachial index is calculated by dividing the higher ankle, or dorsalis pedis, or posterior tibial, the systolic pressure in each lower extremity. You want to divide that by the brachial artery left or right systolic pressure. So an ankle brachial index of less than 0.90 is abnormal. An ankle brachial index of 0.91 to 1.3, that's normal. And anything greater than 1.3 is suggesting a calcified or uncompressible vessel. Additional vascular studies should then be considered. So normal, you always want to be between 0.91 to 1.30 or 1.3. Anything greater than 1.3, now you're talking about a vessel that has too much tension, and that either could be caused by calcification or something else. Then you have iliac syndrome or Leydig syndrome, like we said earlier. This is an arterial occlusion at the bifurcation of the aorta into the common iliac arteries. There's a triad of bilateral hip pain, thigh pain, and buttock claudication. There could be impotence and symmetric atrophy of bilaterally the lower extremities, and that's due to the chronic ischemia. Impotence is always going to be almost always going to be present in men, and any type of absence of impotence should lead you to think of another type of diagnosis because of the small vessels there, which are easily affected. So if it's not affected, then you should be thinking about something else. In aortoiliac syndrome or Leydig syndrome, the pulse is going to be a soft pulse with absent bilaterally from the groin distally, and in the absence of vascular examination, so that diagnosis can be missed. So always check for bilateral pulses. If they're soft or absent, that's another obvious sign of feature of peripheral artery disease or Leydig syndrome. Men with their predisposition to atherosclerosis, if they're smokers, are at highest risk for the condition. So the next topic is your DVT. And how do you evaluate a deep vein thrombosis? First of all, is there a pretest probability of there being a DVT? Well, that's using the Wells criteria. So if it's likely that they do have a DVT or a pretest probability of having a DVT, then what you want to do is something called compression ultrasonography. If compression ultrasound is positive, then you want to go ahead and anticoagulate them, giving them anticoagulation as treatment. If they do not, or if they have negative compression ultrasonography, then it's unlikely to be a DVT, but it's still suspicious, so you want to repeat that ultrasound in a week. However, what if you do not have a pretest probability of having a DVT? How would you evaluate that DVT, or that what you were thinking of it was a DVT? You want to do a D-dimer testing. So D-dimer actually is done if it's unlikely to be a DVT. If it's low, if a D-dimer level is low, then it's unlikely to be a DVT. However, if a D-dimer is elevated, you want to go to compression ultrasonography, and if that's positive, anticoagulate them. Or if it's unlikely, or if it's negative, then you want to just repeat the ultrasound in a week. So what are the clinical features of a DVT? There's pain, there's swelling, there's discoloration of the leg. Differential diagnoses of DVTs would be like venous insufficiency or a ruptured Baker cyst. Post-thrombotic syndrome and cellulitis can all mimic the signs of a DVT. Also, how would you treat patients with clinical evidence of a PE? Would have pleuritic chest pain, dyspnea, tachypnea, tachycardia, and you want to begin anticoagulation therapy immediately while undergoing diagnostic evaluation. So if they ask you in a question stem where they give you a patient that's presenting with signs and symptoms of a DVT causing a PE, what is the next best step? It's to anticoagulate them. Forget all the Wells criterias and D-dimer testing and compression ultrasounds. You just go straight to anticoagulating. Okay? And so patients without a PE and they only have DVT suspected, then you want to go and diagnose before you give the anticoagulants. So if they have if they do have a PE with a DVT that's suspected, you anticoagulate. But if you are only suspecting a DVT without a PE, then you want to just confirm it before you give the anticoagulants. And the compression ultrasound is going to be the preferred test there. And a proved DVT, if it's proven, then you want to begin anticoagulation with heparin. You obviously want to bridge that heparin with warfarin, or rivaroxaban, or apixaban. So we were talking about the Wells criteria. So what is the modified Wells criteria, or basically what is the criteria for a pretest probability of having a DVT? And it's divided into how many points you're scoring. So each one of the following is going to be 1 point. And when you tally up the scores, if it's less than 1 point, it's unlikely. If it's more than 2 points, it's most likely a DVT. So one of the points are a previously documented DVT or active cancer, if they're actively having cancer at the moment, or a recent immobilization of the legs, like if they've been hospitalized or they've had a back injury or something where they can't be mobilized. Recently bedridden, so there you go, more than 3 days. Localized tenderness along with a vein distribution, a swollen leg, calf swelling that's more than 3 centimeters compared to the other leg. Collateral superficial non-varicose veins can also be a pretest probability of a DVT, as well as alternating the diagnosis is a most likely -2 points. Is going to be an alternate diagnosis. So if you're thinking something else, then obviously that's -2 points. So here, as you can see, they have, once you have one of these points, there's most likely going to be another one. So that's the way I see it. If you are bedridden, immediately that means that you have immobilization of the legs, kind of. So that's 2 right there, and that means that you might have a DVT. So it's things like that you need to consider. Or calf swelling, if one leg is more swollen than the other and they've been immobilized, or if they've been previously documented with a DVT. Those are all 1 point. Again, if it's less than 1 point, then it's not likely to be a DVT. But if it's 2 points or greater, then it is likely. And if it's likely to be a DVT, then you want to ask yourself, are they having a pulmonary embolism or are they not? Or are they having signs and symptoms of having a pulmonary embolism? Because if they are, then you want to do anticoagulation. If not, then you want to do the compression ultrasound. Okay, next topic is your pulmonary embolism. And clinical features here would be pleuritic chest pain, like we said before. That chest pain is not going to improve when you lean forward. They can have dyspnea, tachypnea, tachycardia. They can have cough, hemoptysis, or lower extremity pains. And there can also be swelling, suggesting a DVT, and prolonged immobility. Chest x-ray, the chest x-ray would be abnormal in a PE, but it has a poor sensitivity and specificity, so you just can't rule in anything with a chest x-ray. Atelectasis infiltrates, pleural effusions, the Westermarck sign, which is a peripheral hyperlucency due to the oligomia. And there's your Hampton's hump, which is peripheral wedges of lung opacities due to a pulmonary infarction. That's your wedge-shaped infarct in the periphery of the lungs. And your Fleischner's sign, which is an enlarged pulmonary artery. So if you see a very large artery, that's just because the embolism, pulmonary embolism just got stuck at a certain point and everything started backing up behind it. That's called the Fleischner's sign, and that's an enlarged pulmonary artery, which is a sign of pulmonary embolism. So another modified Wells criteria, a pretest probability for a PE, would be if it's a little bit different here because this is for a PE. The one that we said earlier was for a DVT, where you have a bedridden patient or calf swelling, pitting edema, active cancer, documented DVT. Those are for a DVT, the Wells criteria for a DVT. Now, what are the Wells criteria pretest for a probability of a PE? And that's based on also scores, so 1 or more points. If they have certain things, it could be 1.5 points or it could be up to 3 points. So one of the things that give you 1 point on a pretest probability for a Wells criteria for the PE would be cancer or hemoptysis. Either one of those will give you 1 point. A score of 1.5 points are going to be if you had a previous PE or DVT, or if your heart rate is tachycardic at more than 100, or if there has been a recent surgery or immobilization. That will give you 1.5 points. And a score of more than 3 points is that if you have actual clinical signs of having a DVT and the alternate diagnosis is less likely than a PE, that's 3 points. So if you have more than 4 points, then a PE is likely. Less than 4 points, a PE is unlikely. This is a kind of confusing criteria here, so I like to just refer back to the signs of a PE, which would be your tachypnea, sudden onset of shortness of breath, chest pain, and all that. Moving on. We have your, and then heparin also is given if there is a high probability of having a PE, like we already said. Okay, so moving on, guidelines for lipid-lowering therapy. So some of the guidelines for lipid-lowering therapy can be if there is a clinically significant atherosclerotic disease, like if there's an acute coronary syndrome or an MI, stable or unstable angina, coronary or other arterial revascularizations that have happened recently, a stroke, TIA, peripheral artery disease. And if that's the case, then you want to find out what's the recommended therapy. So if they're less than 75 years old, it would be to give them a statin. If they're older than 75 years old, then you want to do a moderate intensity statin. So high intensity statin for younger patients less than 75 years old, and moderate intensity statins for if they're over 75 years old. If their LDL is greater than 190, you have to give them a high intensity statin. If their age is between 40 to 75 years old but with diabetes, then you want to see what is their 10-year cardiovascular disease risk. So if it's high, then you want to give a high intensity statin. If their 10-year risk is low, less than 7.5%, then a moderate intensity statin. And then you want to ask yourself, what is the estimated 10-year risk at all? And then if it's greater than 7.5, then you either choose moderate or high intensity statin. So obviously, if you have a high probability of having coronary vascular disease, or if you're older than 75, you want to, or if you're younger than 75, you want to give a high intensity statin. All right. So there is no recommended LDL level here, but it should be checked after starting statins to assess if there is going to be any kind of response, or if the patient is actually adhering to that medication. That's why you do LDL levels. All right, cholesterol crystal metabolism. This is for atheroembolisms. So risk factors here for a cholesterol crystal embolism would be comorbid conditions like hypercholesterolemia. There can be hypertension, type 2 diabetes mellitus, and a cardiac catheterization or vascular procedure. All those are risk factors for crystal embolization, cholesterol emboli. So clinical features of a cholesterol emboli would be divided into organ systems. So dermatological features would be like lividio reticularis, ulcers, gangrene, blue toe syndrome. Renal causes could be acute or subacute kidney injury. For central nervous system causes could be strokes, amaurosis fuga. There can be ocular involvement like a Hollenhurst plaque, or GI clinical features could be like intestinal ischemia or pancreatitis. So how would you diagnose a cholesterol emboli? And it's with either lab findings like an elevated serum creatinine, eosinophilia is a big one, or hypocomplementemia. low complement levels. Also, on urine analysis, it's typically going to be benign with few cells or casts, but they may have eosinophiliuria. So remember those eosinophils with cholesterol embolizations. And on the skin or renal biopsies, you can have biconcave needle-shaped cleft cells with occluded vessels or perivascular inflammation with eosinophils. So this can be immediate or delayed. There could be more than 30 days after the inciting event. Advanced age, so you'll see cholesterol emboli with older people, smokers or obese patients who are also at risk. Skin manifestations are going to be the most common, like the blue toe syndrome, and those it's going to be your cyanotic toes that have intact pulse with intact pulses. And then you'll have your livedo reticularis, which are blanching patterns. It's like a lace-like pattern on your skin, and it blanches with pressure. If you apply pressure, it blanches away. That's a common image that they like to show, and what it's associated with, and that's a cholesterol emboli. And some may have persistent renal failure that lasts for more than 2 weeks, in contrast to a dye-induced renal injury, which usually resolves within a week. So remember, these patients will have renal failure that lasts more than 2 weeks. And how do you treat? Supportively, and you want to reinforce with a statin. All right, next topic is acute limb ischemia. So for acute limb ischemia, this occurs from arterial occlusions caused by those cardiac embolizations or thromboses. And examples here would be like vascular stents or hypercoagulable states, as well as traumas. Major cardiac sources of the arterial emboli, like a left ventricular thrombus or a thrombus formation due to an atrial fibrillation. And that's usually found on the left side, the left atria, can cause acute limb ischemia with the thrombus. Then you have aortic atherosclerosis can cause a thrombus, not a thrombus, it can cause acute limb ischemia. Patients with large anterior ST wave elevation MIs are at high risk for left ventricular thrombus and anteroapical aneurysm formation. There's acute arterial occlusions of extremities, of the extremity that leads to the 6 Ps. So that arterial occlusion acutely is going to cause pain, pallor, poikilothermia, which are cool extremities, paresthesias, pulselessness, and paralysis. Immediately, you want to start them on anticoagulation and vascular surgery evaluation while further diagnostic procedures are performed. And you want to give them IV heparin to prevent any further thrombus propagation and thrombosis if distal arterial and vein circulation is happening. So transthoracic echo with echo contrast must be performed to screen for a left ventricular thrombus and to evaluate left ventricular function. All right, next up is carotid endarterectomy. And this is a lesion where it's less than 50%, are typically monitored with an annual duplex ultrasound. They're medically managed at this stage with pharmacotherapy like antiplatelet agents and statins, and there's a risk factor optimization like tobacco cessation, diabetes mellitus, and hypertension control. So that's how you would manage the risk factors. Asymptomatic carotid artery stenosis can progress to a TIA or an embolic stroke, and then symptomatic means that there can be an occurrence within the past 6 months of sudden onset focal neurological symptoms corresponding to carotid artery lesions. So what are some of the indications for a carotid endarterectomy? In men, asymptomatic men with 60 to 99% stenosis require endarterectomy. Or if they're symptomatic, they need to have 70 to 90% for a grade 1A stenosis or a grade 1A endarterectomy, or 50 to 69% of stenosis for a grade 2A. In women, both asymptomatic or symptomatic, the stenosis has to be between 70 to 99% stenotic. So remember here, 70. So at 70% stenosis, in women, you need a carotid endarterectomy. In men, if they're symptomatic, or if they're asymptomatic, at 60% stenosis. That's when a carotid endarterectomy is indicated. Okay, so next topic is syncope. Now, what are some of the likely etiologies of syncope and the clinical clues to that diagnosis? So the likely etiology would be like vasovagal or neurally mediated syncope. And here the triggers would be like a prolonged standing or emotional distress, painful stimuli, also prodromal symptoms like nausea, warmth, and diaphoresis. These are all vasovagal neural mediated syncopes. Situational syncope, the triggers here would be like cough, micturition, or defecation, going to the bathroom, peeing, pooping, coughing. These can cause a syncope that's called situational syncope. Also, orthostatic hypotension due to postural changes in heart rate, blood pressure after standing up suddenly, that's orthostatic hypotension. If there's syncope with exertion or syncope during exercise, that's a sign of an aortic stenosis, hypertrophic cardiomyopathy, or it could be anomalous coronary arteries. Ventricular arrhythmias, if there's a prior history of coronary artery disease or myocardial infarction, also cardiomyopathy or reduced ejection fraction. You have your sick sinus syndrome and bradyarrhythmias as well as AV blocks, and these cause sinus pauses on the monitor, on the EKG monitor, with prolonged PR intervals and QRS durations. Then you have your torsades de pointes, which is your acquired long QT syndrome. That's also a cause of syncope. And here the clinical clues to diagnose torsades would be like hypokalemia, hypomagnesemia, and medications that cause prolonged QT intervals like Sotalol is the one that they like to ask. Then there's congenital long QT syndrome, which is a form of torsades, but you just are born with it. And that's a family history of sudden death with a prolonged QT interval on EKG, syncope with triggers. And those triggers are like exercise, swimming, sudden noises during sleep. If you're doing any of that or you experience any of that, it can lead to a sudden death due to prolonged QT elongation. Now, vasovagal syncope. So what are some of the causes here? So if you're less than 60 years old, some of the events that can cause vasovagal syncope would be like emotional or orthostatic stresses, like a venopuncture, prolonged standing, exposed to heat, or exposed to a lot of exertion. That can be an inciting event for vasovagal syncope. But if the patient's older than 60 years old, also you can add on triggering if they have to go to the bathroom by micturition, defecation, coughing as well. And symptoms of vasovagal syncope would be a prodrome of pallor. There could be dizziness, nausea, diaphoresis. And if there's a short duration of the syncope, that would be a syncope that lasts seconds to a few minutes. And then symptoms are going to improve with the supine position. How do you diagnose a vasovagal syncope? It's mainly it's a clinical diagnosis. The upright tilt table testing is done in uncertain cases where you have a patient lie on a table that can move up and down. The head of the bed can go up or down, and that's your tilt table test. But it's mainly it's a clinical diagnosis. And treatment is preventive measures to avoid triggering activities like prolonged standing. I mean, if standing is causing you the vasovagal syncope, a treatment is to stop standing. It's not very complicated there. So it's most commonly due to excessive vagal tone. Also, it's known as neurocardiogenic syncope, and it's particularly common in young women. It could be benign or self-limited in most cases, and the diagnosis is usually made clinically, like we said, and it doesn't need any kind of further testing if there's a history or a physical exam that strongly points to that diagnosis, as well as if their resting EKG is going to be normal. During an upright tilt table test, however, the patient is going to lie down, it's strapped to an examination table, and there's going to be a continuous EKG and blood pressure monitoring that are used throughout the test. The exam table basically moves up or down, supine with the head up in the positions at around 60 to 90 degrees, and then the patient is held in that position for about 20 to 45 minutes. If there are signs of unconsciousness like syncope or the inability to maintain posture due to a fall in blood pressure or pulse, then the diagnosis is confirmed and the test is stopped. The test has to be limited. It has a limited sensitivity and specificity, so that's why it's not really used, and it's just more time and equipment needed when you can just as easily diagnose this clinically. Carotid sinus hypersensitivity syndrome is a syncopal episode that's triggered by neck movement or pressure on the carotid sinus by tight neck collars. So this is actually kind of common. This is caused by unexplained falls in older adults. So if you have an older adult who falls for no reason, and maybe they were wearing a tight collar, that's called carotid sinus hypersensitivity syndrome. And here, what's recommended is carotid sinus massage. And that's considered diagnostic if the patient develops asystole for more than 3 seconds and a fall in systolic blood pressure more than 50, or a reproduction of symptoms like syncope. Situational syncope is a specific situation like going to the bathroom, micturition, coughing, pooping, peeing, can lead to syncope. Commonly, it's found in middle-aged or older males. And here the mechanism of action of a situational syncope is autonomic dysregulation, which can partially be explained by either straining or rapid bladder emptying. There's a cardioinhibitory response and a vasodepressor mechanism that can be involved. Then you have orthostatic hypotension. That's a drop in the systolic blood pressure of more than 20 millimeters of mercury and a drop of more than 10 millimeters diastolic on standing from a sitting position within 2 to 5 minutes of standing from the supine position. So they'll give you 2 blood pressure readings, one when you were sitting, and it could be 120/80, and the following could be 100/70. Okay, so this is due to a decrease in baroreceptor sensitivity that leads to a decrease in constriction of resistance and capacitance vessel. There's a decreased intravascular volume, hypovolemia, and medications are going to decrease catecholamines and nerve endings and decrease myocardial sensitivity to sympathetic stimulation. Autonomic nephropathy or neuropathy like diabetes and Parkinson's disease, elderly patients, and prolonged recumbence of increases the risk. People often note that presyncopal lightheadedness sensation, and there's an increase in BUN. The BUN creatinine ratio is also sensitive, but again, it's not a specific indicator of hypokalemia, and that's because of a decrease in GFR and the increase in urea reabsorption. The BUN creatinine ratio is going to be increased with increasing severity of the hypovolemia, and the urine sodium, especially of the patients on a diuretic as well, is going to be increased. The blood potassium, lactic acidosis, they're not sensitive indicators of hypovolemia. So next topic is aortic stenosis. So in aortic stenosis, there's going to be syncope, fatigue, there's a decrease in pulse pressure, there's something called pulsus parvus retardus, which is a weak delayed pulse, a crescendo-decrescendo murmur at the right upper sternal border. There's a soft and single S2, and that's due to a delayed A2 and a P2. Hence, there's going to be a single soft murmur heard with aortic stenosis. An early peaking systolic murmur would show mild to moderate stenosis, versus a late peaking systolic murmur is severe aortic stenosis. So remember, early is mild to moderate, a late murmur is severe. So pulsus parvus attardus is an atrial pulse with decreased amplitudes and a delayed peak, and it's common in severe aortic stenosis. Aortic regurgitation is the next topic. So what are the common causes of aortic regurgitation? So there's aortic root dilation, such as in Marfan syndrome or syphilis. There can be post-inflammatory causes like rheumatic heart disease, endocarditis, or congenital bicuspid aortic valves. The pathophysiology here with aortic regurgitation is that it's a backflow from the aorta into the left ventricle. That's going to cause an increase in left ventricular end diastolic volume, with compensatory myocardial hypertrophy and a ventricular enlargement that initially maintains the stroke volume and the cardiac output. Also, there could be an excessive left ventricular stretching that later on leads to a decrease in stroke volume, and that's going to decrease the forward blood flow, and it's going to decrease systolic heart failure. Also, the pathophysiology of aortic regurg is that there's going to be an increase in left ventricular end diastolic pressure, and that's going to lead to pulmonary congestion. So what are the features of aortic regurg? You have a diastolic decrescendo murmur with a wide pulse pressure, and that's an increase in systolic blood pressure and a decrease in diastolic pressure. So you'll have a really wide pressure ranges. So you'll see like 190 over 70, for instance. Something called a collapsing water hammer pulse is also found, as well as heart failure signs and symptoms. So the murmur here could be high-pitched. A blowing is the best way to describe it, a high-pitched blowing murmur that's best heard along the left lower sternal border. It may be soft, and it's heard in some patients only by applying firm pressure with the diaphragm while the patient is sitting up, leaning forward and holding their breath on full expiration. So if you see that scenario, a patient who's having their heart auscultated and the physician's applying pressure on the diaphragm while the patient's sitting up, leaning forward and holding their breath in full expiration, that's usually going to be because of aortic regurgitation. Left ventricular enlargement is going to bring the apex close to the chest wall, and it causes uncomfortable sensations of heartbeats and a pounding sensation, especially in the left lateral decubitus position. A water hammer pulse is also called the Corrigan's pulse, and in developed countries, its most common cause is due to a bicuspid aortic valve or an aortic root dilation. So in developing countries, aortic regurgitation is due to a bicuspid aortic valve or an aortic root dilation, but in developing countries, it would be rheumatic fever. Okay, so pulsus bifringens, or a biphasic pulse. These are two strong systolic peaks or aortic pulses from the left ventricular ejection separated by a mid-systolic dip. It can be palpated in patients with significant aortic regurgitation with or without stenosis, HOCM, and occasionally there's going to be a large PDA. So what are some of the common causes of aortic regurgitation? So you have aortic valve diseases that cause aortic regurg, and ascending aorta or aortic root diseases that causes aortic regurg. So the valve leaflet itself or the root, or the ascending aorta. So if it's the valve leaflet that's diseased, causing aortic regurgitation, think about rheumatic heart diseases, endocarditis, a bicuspid aortic valve, trauma, myxomatous degeneration of the valve, ankylosing spondylitis can cause aortic regurg, and that leaflet, acromegaly, and medications such as fenfluramine, phentermine, which is your fen-phen. Then ascending aortas or an aortic root disease itself, so the root itself, that can be caused, the aortic regurgitation there could be caused by hypertension, aortitis, such as in syphilis, ankylosing spondylitis as well, a dissecting aortic aneurysm, Ehlers-Danlos, can cause aortic root disease. So don't be so try not to get that confused. So in valvular leaflet diseases, it's acromegaly that can cause it, versus root diseases would be Ehlers-Danlos. Inflammatory bowel diseases causes an aortic root disease, leading to aortic regurg. Inflammatory bowel disease, reactive arthritis, and Marfan syndrome. So both Marfan's and Ehlers-Danlos causes aortic root diseases, but acromegaly causes leaflet disease. So, infective endocarditis. So vascular and immunological manifestations of infective endocarditis. So here there's a vascular phenomenon or immunological phenomenon that can cause an infective endocarditis. And the vascular phenomenons would be systolic embolizations, cerebral pulmonary or splenic infarcts. Those are like systemic emboli. A mycotic aneurysm, or Janeway lesions. These are macular erythematous non-tender lesions on the palms and the soles. Those are all vascular phenomenons of infective endocarditis. Now, immunological phenomenons of infective endocarditis would be like Osler's nodes, which are painful violaceous nodules, like purplish nodules seen on the fingertips and toes, as well as Roth spots, which are edematous and hemorrhagic lesions in the retina. So if you see any of those, think of infective endocarditis. There's an abnormal urine. So in the urine, you'll see proteinuria with or without hematuria. There can be swollen intraphalangeal joints seen in arthritis. And also extensive evaluation is going to be needed for that definitive diagnosis. Empiric treatment of infective endocarditis is with vancomycin. You want to give vancomycin after obtaining blood cultures. And that's going to cover staph, strep, and enterococci. And most viridins groups that are going to be highly susceptible to penicillin with minimum inhibitory consequences, so less than 0.12 micrograms. In infective endocarditis, penicillin susceptible strains should be treated with IV penicillin G, and that's every 4 to 6 hours, or 24 hours of continuous infusion. Or you can give them IV ceftriaxone once a day for 4 weeks. Ceftriaxone is going to be easier to administer at home due to the once a day dosing. There's oral antibiotics, but they're generally not recommended as initial therapy in patients with infective endocarditis, and it can be considered in some patients, but then combination therapy is given rather than monotherapy. Remember that ceftriaxone is a IV medication, so I don't know about administering it at home, but it is once a day for 4 weeks, so that seems like a pretty good deal. Complications of infective endocarditis. There can be cardiac complications, neurological complications, renal complications, musculoskeletal complications. So in cardiac complications of infective endocarditis would be like your valvular insufficiency, and that's the most common cause of death. There could be perivascular abscesses, conduction abnormalities, and mycotic aneurysms with cardiac infective endocarditis. Neurologically, infective endocarditis can be caused by an embolic stroke, by cerebral hemorrhages, by brain abscesses, and as well as an acute encephalopathy or a meningoencephalitis. Renal causes of infective endocarditis could be like renal infarctions or glomerulonephritis, or a drug-induced acute interstitial nephritis from the therapy itself. And then musculoskeletal causes of infective endocarditis would be like vertebral osteomyelitis or septic arthritis, as well as musculoskeletal abscesses. Now, rheumatic fever is our next topic, and in rheumatic fever there's an antibiotic prophylaxis for rheumatic fever that we need to know. So the preferred antibiotic for prophylaxis is going to be an benzathine penicillin G IM every 4 weeks. So you give IM penicillin G for rheumatic fever prophylaxis for 4 weeks. Associated conditions is that if they have rheumatic fever without carditis, the duration of the antibiotic therapy should be around 5 years until they're 21 years old, whichever one is longer. If they have rheumatic fever with carditis but no residual heart disease or valvular disease by clinical or echocardiographic criteria, then the duration of antibiotic therapy would be 10 years until they're 21 years old, or whichever one is longer. If there is rheumatic fever with carditis and persistent heart or valvular disease, then you also want to give 10 years of penicillin prophylaxis, but you do it up till they're 40 years old, whichever one is longer. So remember that rheumatic fever is one of the most common causes of infective endocarditis in developing countries. In developed countries, it's going to be congenital causes like bicuspid aortic valves. All right, so all patients with the diagnosis of rheumatic fever should be treated with antibiotic therapy to eradicate group A strep, regardless of the presence or the absence of pharyngitis at the time of the diagnosis. And patients with a history of renal failure are going to be at increased risk of recurrence, and they're going to be increased risk of progression to right heart disease with repeated episodes of group A strep pharyngitis. Mitral stenosis is going to be almost always due to rheumatic fever. And patients with symptomatic mitral stenosis need preload reduction with diuretics, or they can give nitrates and not afterload reduction with ACE inhibitors. So remember that ACE inhibitors reduce afterload, but nitrates and diuretics reduce preload. All right. Now, Marfan syndrome, what are the clinical features of Marfan syndrome? So skeletal features are going to have arachnodactyly. There's going to be a decrease upper to lower body segment ratio. There's going to be increase in arm to height ratio. So their arms are going to be really long in comparison to the rest of their body. They're going to have a pectus deformity, that their chest caves in. Scoliosis and kyphosis is also seen, as well as joint hypermobility. And the eyes or ocular findings are going to be ectopic lentitis. So here the thing I remember is in Marfan syndrome, they're so tall that the retina detaches and upwards. Because they're so tall, you have to look up. It detaches upwards. Versus homocystinuria, which you have to look down to go pee. They have a downward retinal detachment. Just something I wanted to add there. Cardiovascular causes of Marfan syndrome would be aortic dilation, or not causes of Marfan. Marfan causes cardiac aortic dilation. It can cause aortic regurgitation or dissection, as well as mitral valve prolapse. Pulmonary causes of Marfan syndrome would be spontaneous pneumothorax from the apical blebs. Remember, these patients are really tall and thin. They call them lanky, a lanky boy or lanky people. That just means tall and thin. Think of somebody like Snoop Dogg or something. That's the only thing I can think of. They're so tall and thin that they have risks of spontaneous pneumothorax from the apical blebs. From these little apical blebs, they just explode and cause a spontaneous pneumothorax. On the skin, there's recurrent or incisional hernias, as well as skin striae. All right. Oh, by the way, I'm not saying that Snoop Dogg has Marfan syndrome by any means. He's just tall and lanky. All right. Aortic dissection. So clinical features of aortic dissection, risk factors here would be hypertension, which is the most common cause, Marfan syndrome, and cocaine use. All these can lead to an aortic dissection. Those are risk factors. Clinical features of an aortic dissection would be severe, sharp, tearing chest pain or back pain. That's a big one. And then there's going to be an increase in systolic blood pressure between the arms, and that's going to be more than 20 millimeters of mercury and variation of blood pressure. And then complications of aortic dissection would be strokes can complicate it, such as carotid arteritis, acute aortic regurg, specifically the aortic valves, Horner syndrome, causing superior cervical sympathetic ganglion. There's an acute myocardial ischemia or infarction, and that's in your coronary arteries. Pericardial cavity would consist of pericardial effusions or cardiac tamponade. Hemothorax or pleural cavity can be a feature of aortic dissection. A lower extremity weakness or ischemia due to spinal or common iliac artery involvement, as well as abdominal pain because of the mesenteric artery. So all those arteries are going to be affected, leading to strokes, aortic regurg, Horner syndrome, acute MI, pericardial effusion, hemothorax, lower extremity weakness, and abdominal pain because of the loss in blood supply to those areas, because of the aortic dissection. So in 50% of cases in people that are less than 40 years of age are due to Marfan syndrome, but hypertension is the most common risk factor seen in 75% of patients. So patients with aortic dissection and or progressive aortic root dilation can develop aortic regurgitation murmurs, and those are best heard at the left lower sternal border with the patient sitting up and leaning forward and holding their breath after a full expiration, like we said, aortic regurg. But aortic dissection is this one as well. In aortic dissection, the murmur is heard best on the right sternal border compared to the left in primary vascular diseases. So if you hear it on the right, think of an aortic dissection. The pain can also radiate to the neck. There's a Stanford A and Stanford B involvement, and the Stanford A involvement involves the ascending aorta, so A for ascending, and a type B would be the descending aorta. An acute type A aortic dissection, which goes to the ascending aorta, can occasionally cause occlusion of the right coronary artery by dissecting a flap, by a dissection flap, leading to an inferior MI and an aortic dissection that can extend into the renal arteries, and that can go on to lead to an acute renal failure. So how would you treat type A and type B aortic dissections? Type A, the one that goes up to the ascending aorta, is you treat by acute lowering of blood pressure with labetalol, so a beta blocker, with surgery. And then type B, that goes to the descending aorta, is usually managed with labetalol alone. So if it goes up, just think that it goes up, it's really bad because it goes up to the ascending aorta, can affect the carotid arteries. So you need surgery at that point with labetalol or with the beta blocker. But type B is beta blocker alone. So B for beta blocker alone, A for surgery and a beta blocker. Okay. So the management of a dissecting aortic dissection would be, even if the transthoracic echo has been performed, a transesophageal echo is going to be performed in the ER to confirm the diagnosis, because it's more sensitive and specific, and it helps also visualize the ascending and transverse and descending aorta. The CT or the MRI, or the CT and the MRI, are going to be alternatives to if there's going to be an emergency transesophageal echo if is not available. So if a TEE is not available, a transesophageal echo is not available, then you can do a CT or MRI. Beta blockers are also used as they decrease the rate of the heart rate and they decrease blood pressure. Beta blockers also decrease stress on that aortic wall. Vasodilators should not be used because they can cause reflex tachycardia, further increasing stress on the wall, and it's only used if further blood pressure is going to be lowered after beta blockers has already been given. Okay, and then anticoagulants and fibrinolytics should never be used. Emergency pericardiocentesis is going to be needed in those patients who are not hemodynamically stable, and that's what you should know for aortic dissection. So what would be the diagnostic approach for a suspected aortic dissection? So let's say you do suspect an aortic dissection, and these would be under risk factors like Marfan syndrome or connective tissue diseases, as well as hypertension. Also, some suspicions would be tearing chest pain or abdominal pain that radiates to the back, a perfusion deficit with pulse deficits. There can be differences in blood pressure between the right and the left arm. That's more than 20 millimeters of mercury, as well as you hear a murmur of aortic regurg. If you see any of these as suspicion for aortic dissection, then you do an EKG. The EKG is going to tell you if there is signs, and if there is, then you want to evaluate and treat appropriately. But if there isn't, then you want to see how's their creatinine level. If their creatinine level is normal and they don't have allergies to like contrast, then you would do imaging based on the availability. So transesophageal echo, chest CT without contrast. If they do have a contrast allergy, obviously without contrast, and MRI only if it's a non-emergency or the patient can lie still. Other than that, the most preferred test would be a transesophageal echo. Then you have your heart-hand syndrome, which are both upper limb defects, deformities of the radius and the carpal bone, and an arterial septal defect. Okay, so alcohol withdrawal. So what are some of the manifestations of alcohol withdrawal? You have mild withdrawal symptoms, you have seizures, alcoholic hallucinations, and delirium tremens. We went over this in the psychiatry lecture, but as a recap, mild withdrawal symptoms means the patient has anxiety or insomnia, tremors, diaphoresis, sweating, palpitations, GI upset, but their orientation is intact. And the onset since the last drink, when was their last drink, was between 6 to 24 hours ago. That would cause mild withdrawal symptoms. Next would be seizures. So seizures would be either single or multiple seizures, and they could be generalized or tonic-clonic seizures. And usually these happen within 12 to 48 hours after your drink. Then you have alcoholic hallucinations, such as visual hallucinations, auditory hallucinations. There can be tactile hallucinations, but again, their orientation is intact, and stable signs they're going to have vital signs that are stable. And this would be between 48 to 96 hours after their last drink. So delirium tremens, that's the worst outcome for alcohol withdrawal symptoms. It happens up to 3 days, maybe 4 days in advance. So look for that. Hypertension complications would be hypertensive urgency versus emergency. Hypertensive urgency would be severe hypertension that's usually more than 180 over 120 with no symptoms or acute end organ damage versus hypertensive emergency. There is end organ damage. There's severe hypertension with acute life-threatening complications with organ damage. It could be either malignant hypertension, which is a severe form of hypertension with retinal hemorrhages and exudates, or papilla edema. So if you see anything that has to do with high blood pressure affecting the eye in any way, that would be a hypertensive emergency and a subclassification of malignant hypertension. Versus a hypertensive encephalopathy, which is also part of a hypertensive emergency. That's when you have severe hypertension with cerebral edema and there's non-localizing neurological symptoms and signs. So a malignant hypertension is common in long-standing and uncontrolled hypertension. In malignant hypertension, there can also be malignant nephrosclerosis, acute renal failure, hematuria, proteinuria. That can cause the kidneys to get damaged, causing a malignant nephrosclerosis. However, that's not always present, and it's not always a diagnostic criteria. So in a hypertensive emergency, remember severe hypertension with end organ failure. The blood pressure should be lowered 10 to 20% within the first hour and 5 to 15% within the next 23 hours. If there's an excessive drop in the blood pressure, that can lead to a cerebral ischemia with altered mental status or a generalized seizures. And a hypertensive encephalopathy, that's increased blood pressures with signs and symptoms of cerebral edema. Clinical features would have headaches, nausea, vomiting, non-localizing neurological symptoms. There can be restlessness, confusion, agitation, seizures, and a coma. And the patient can also develop intercerebral or subarachnoid hemorrhage. So what is a workup of hypertension? How would you work up these people? So most people have essential hypertension, but initial evaluation should assess the possible secondary causes. So the basic workup is going to include, first of all, trying to figure out the duration of the hypertension, what the extent of the target organ damage has caused, or if there's any kind of cardiovascular risk factors. Next would be labs. So basic labs are going to include urine analysis for acute hematuria or proteinuria and the protein creatinine ratio, chemistry panel, also lipid profile to see if there's any risk stratifications for coronary artery disease. There's a baseline EKG that you need to evaluate for coronary artery disease or a left ventricular hypertrophy, and then further evaluation is needed for those that have signs and symptoms of possible secondary hypertension. So how would you treat hypertension? So the JNC 8 recommendation for treating hypertension would be, let's say if they're older than 60, you want to initiate treatment if the systolic blood pressure is more than 150 or if the diastolic pressure is more than 190. So the goal of these patients is to reduce the blood pressure to less than 150 over 90. Now, if they're younger than 60 years old with chronic kidney disease or diabetes, when do you want to initiate initiate treatment for hypertension would be if their systolic blood pressure is more than 140 and their diastolic pressure is more than 190, and then your goal in blood pressure treatment is to decrease the blood pressure to less than 140 over 90. So what is the initial treatment of choice? So here you have to do it by ethnicities. So in the black populations, thiazide diuretics or calcium channel blockers alone or in combination, so ACE inhibitors or ARBs are not going to be first line within the black community. Other ethnicities, you can start them off with a thiazide diuretic as well. But here you can give them ACE inhibitors, ARBs, or calcium channel blockers. But you give it to them alone or in combination. And then all ethnicities with chronic kidney disease or diabetes, whoever has chronic kidney disease or diabetes, should be on an ACE inhibitor or an angiotensin receptor blocker, again, alone or in combination with drug classes. So remember, thiazides are going to be always your first to go drugs unless they tell you this person is at risk or has diabetes, then you want to think ACE inhibitors. So there's one called isolated systolic hypertension. So ISH is also a mnemonic. This is when you have just the systolic hypertension. And the initial treatment here is a monotherapy with low-dose thiazide diuretics, ACE inhibitors, or a long-acting calcium channel blocker. Also, systolic hypertension can also occur in hyperthyroidism because of a hyperdynamic state. There's signs of hyperdynamic states like ventricular heaves or a dynamic precordium upon examination. And most common features would be mitral regurgitation, which are exertional dyspnea and fatigue, secondary to a decrease in cardiac output and an increase in left atrial pressures. There's a dry cough that can occur in the case of a left ventricular dysfunction, in more cases causing a pulmonary congestion or an edema. So the treatment for hypertension are going to be modifiable first. So what are some of the modifiable treatments? Weight loss, the DASH diet, exercise, reducing dietary sodium intake and alcohol intake. So for weight loss, you want to decrease the BMI to less than 25. And approximately you want to decrease the blood pressure to about 5 to 20 per 10 kilograms lost. So that's why you want to do that, to decrease the systolic blood pressure. The DASH diet is recommended as a diet that's high in fruits and vegetables and very low in saturated fat and in total fat. And that will decrease the systolic blood pressure between 8 to 14. Exercise 30 minutes a day for 5 to 6 days a week will decrease your systolic blood pressure to 4 to 9 millimeters of mercury. Dietary sodium that's less than 3 grams a day will decrease at 2 to 8 millimeters of mercury. And alcohol intake, limiting yourself to 2 drinks a day in men or 1 drink a day in women, will decrease systolic blood pressure from 2 to 4 millimeters of mercury. So obviously a combination of all of that would be the most effective. Weight loss being the most effective in targeting a decrease in systolic blood pressure. So the most effective method to control hypertension is lifestyle modification. Reducing weight is going to be the most important in obese patients. That DASH diet is most important in non-obese patients. And this has more importance than lowering the sodium diet to lower blood pressure. So if you ever see a question that asks, which of the following is the best initial step to manage the patient on this hypertension, you have to see if they're obese or not. If they are obese, you want to just have them lose weight. If they're not obese, you want to give them the DASH diet. And it's tricky because both options are going to be there. So DASH diet for non-obese, reducing weight for obese. Lowering sodium is not as important or not as effective. It is still important, but it's just not as effective. Okay, antihypertensives in pregnancy. So first-line antihypertensive medications in pregnancy that are safe, which would be your methyl-dopas, beta blockers like labetalol, hydralazine, calcium channel blockers like nifedipine. Second-line medications, antihypertensives in pregnancy would be thiazide diuretics and clonidine. And absolute contraindications in pregnancy would be ACE inhibitors, ARBs, aldosterone blockers, or direct renin inhibitors, as well as furosemide. So calcium channel blockers and peripheral edema. Calcium channel blockers are going to cause peripherentiation of dilation of the capillary vessels, so you'll have arterial dilation, and that causes an increase in hydrostatic pressure in the capillaries, and that then causes edema. Also, it causes headache, flushing, and dizziness, and ACE inhibitors and ARBs cause dilation of post-capillary venules when used in combination with calcium channel blockers. So there is a lower risk of calcium channel blockers associated with peripheral edema by normalizing the capillary pressure. Cyanide toxicity is our next topic. Nitroprusside, which is a quick onset and offset, and it's used in hypertensive emergencies. And it's given, if given for a longer duration or in higher doses, it can actually cause renal insufficiency. Clinical features for cyanide toxicity, they'll have altered mental status, lactic acidosis, seizures, and a coma. Beta blocker toxicity. For beta blocker toxicity, it would be bradycardia, hypotension, AV blocks, cardiogenic shock. There can be wheezes because of the constriction of causing bronchospasm, hypoglycemia. There could be neurological like delirium, seizures, etc. with beta blocker toxicity. An AV block, hypotension, and bradycardia can all occur with calcium channel blockers as well, anticholinergics, and also digoxin. So what is the management for beta blocker toxicity? So obviously the first step is the airway. You want to secure their airway. Give isotonic fluid boluses and IV atropine if they have hypotension and bradycardia. Also, IV glucagon if refractory or profound hypotension, and that's going to lead to an increase in cyclic AMP, and it's effective in beta blocker and calcium channel blocker toxicity. Other therapies that can be used simultaneously or in succession would be like IV calcium, vasopressors like epinephrine and norepinephrine, high doses of insulin and glucose, and IV lipid emulsion therapy as well. All right, moving on. Secondary causes of hypertension. So you have renal and parenchymal diseases as a cause of hypertension, renal vascular diseases. There could be primary aldosteronism, pheochromocytomas, Cushing's syndrome, hypothyroidism, primary hyperparathyroidism, and coarctation of the aorta. These are all secondary causes of hypertension. So in a renal parenchymal disease, the clinical features would be elevated serum creatinine and abnormal urine analysis with proteinuria and red blood cell casts. For renal vascular disease, this would be severe hypertension, more than 180 millimeters of mercury systolic, or more than 120 diastolic after the age of 55. And it could also be a possible recurrent flash pulmonary edema or a resistance in heart failure. And there could be an unexplained rise in serum creatinine, as well as abdominal bruits. In primary aldosteronism, this is an easily provoked hypokalemia with slight hypernatremia, hypertension, and adrenal incidentaloma. In a pheochromocytoma, clinical features would be paroxysmal elevated blood pressures with tachycardia, pounding, headaches, palpitations, diaphoresis, hypertension with an adrenal incidentaloma. For Cushing syndrome, there'll be central obesity, facial plethora. There could be proximal muscle weakness, abdominal striae, ecchymosis, as well as amenorrhea and erectile dysfunction, hypertension with adrenal incidentaloma. And for hypothyroidism, this would cause fatigue, dry skin, cold intolerance, constipation, weight gain, bradycardia, all signs of hypothyroidism to begin with. Primary hyperparathyroidism would cause your hypercalcemia, polyuria, polydipsia, kidney stones, neuropsychiatric presentations like confusion, depression, psychosis. Those are your psychiatric overtones. For primary hyperparathyroidism, hypercalcemia, bones, moans, and psychiatric overtones. Coarctation of the aorta is also going to cause differential hypertension with brachial femoral pulse delay. Okay, so all patients with resistance in hypertension, severe or malignant, with a sudden BP rise in a patient that's previously been controlled with blood pressure, the age of onset less than 30 years without a family history of hypertension, these patients should be screened for secondary causes of hypertension. So basically, any patient that has severe hypertension in the family history and any type of family history where their hypertension has been started when they're less than 30 years of age, then they should be screened for secondary causes of hypertension. Anybody who's resistant to with a resistant hypertension, that's a persistent hypertension despite having 3 antihypertensive agents. It's not that you are resistant to having hypertension, it's that you have hypertension that's resistant to medication. That's what it should be actually called. And specifically, the patient has tried over 3 antihypertensive agents, all different classes, and one of them has to be a diuretic, and they still have hypertension. That's a resistant hypertension. And also significant hypertension with primary hyperparathyroidism is going to suggest possible evaluations of Men's syndrome because of a pheochromocytoma. All right, moving on, we have renal vascular hypertension and renal artery stenosis. These are most common and the most correctable secondary causes of hypertension. It's not responsive to antihypertensives, and they should be suspected and evaluated in these following cases. So basically, when your serum creatinine is more than 30% of baseline after starting an ACE inhibitor or ARB. So if they're on an ACE or ARB and their serum creatinine is still 30% above baseline, that's when you should be evaluated. That's one of the evaluation criteria. Severe hypertension in patients with diffuse atherosclerosis as well. Hypertension in a patient with asymmetric kidney sizes or small atrophic unilateral kidney, especially common in patients with a history of atherosclerotic disease and abdominal bruits. So that's a big one. Atherosclerotic disease with an abdominal bruit is a very important sign of renal artery stenosis and renal vascular hypertension, as well as systolic diastolic bruits. Heard in this case, only systolic bruits are heard in a AAA. So in an abdominal aortic aneurysm, you're only going to have a systolic bruit, but in a renal artery stenosis, it's going to be a systolic and diastolic bruit. And that's a 99% specificity and 40% sensitivity. All right, so also a difference in blood pressure within the arms. So in the left arm, then the right, that's a subclavian atherosclerosis. So if you hear it on the left more than the right, subclavian atherosclerosis. If it's on the right more than the left, then that's coarctation proximal to the left subclavian artery origin. In case of an aortic dissection, but the chest pain is radiating to the back, that's also present. All right, so autosomal dominant polycystic kidney disease. So here we have symptoms of, patients are actually symptomatic with autosomal dominant polycystic kidney disease. They do, however, have hematuria. They can have flank pain due to nephrolithiasis, infection, cyst rupture, or hemorrhage. Clinical signs would be hypertension. There could be a palpable abdominal mass, and that's usually bilateral palpable abdominal masses, proteinuria, as well as chronic kidney disease. Extrarenal features would be like cerebral aneurysms, hepatic and pancreatic cysts, cardiac valve disorders such as mitral valve prolapse, aortic regurgitation, colonic diverticulosis, and a ventral and inguinal hernia. And the diagnosis is usually done with an ultrasound. Alternatively, it's a CT is done with an MRI, and that shows multiple renal cysts. The management of an autosomal dominant polycystic kidney disease is to follow the blood pressure and the renal function, to give aggressive control of cardiovascular risk factors, including hypertension, and then give ACE inhibitors that are preferred here, in this case, for their high blood pressure. And in end-stage renal diseases, you want to give dialysis and renal transplant, or that should be thought of to do as a renal transplant. And then hypertension is usually precedes the decline in renal function. Fibromuscular dysplasia, that's the most common cause of secondary hypertension in children. It's usually women, 15 to 50 years of age. It's a non-inflammatory and non-atherosclerotic condition. There's abnormal cell growths in the arterial wall, and that leads to a vessel stenosis and aneurysm or a dissection. On physical examination, there could be a hum or a bruit in the CVA angle due to a well-developed collateral arteries. The right kidney is going to be more affected than the left kidney, and that's going to increase renin and angiotensin, and that's going to cause your secondary hyperaldosteronism. But the ratio of renin, angiotensin, and aldosterone is going to remain less than 20. There's also going to be a carotid bruit heard. Angiography is done, and you can see a string of beads appearance on the renal artery. If you see that string of beads, or they show you an angiography where it just looks like beads on a string, it's a female that's young, under 50 years of age, with hypertension. It's most likely going to be a fibromuscular dysplasia. So what are some of the clinical features of fibromuscular dysplasia? So again, women age less than 50 with either severe or resistant hypertension, an onset of hypertension that started before they were 35 years old. There could be a sudden increase in blood pressure from baseline, as well as an increase in creatinine that's about more than 1 milligram per deciliter of creatinine increase, especially after starting an ACE inhibitor or an ARB without any kind of significant effect on the blood pressure. So you give them the ARB, you give them the ACE inhibitor, and there's still no effect on lowering the blood pressure. And obviously you'll have a systolic, diastolic epigastric bruit. Remember, renal artery diseases, renal artery hypertension, fibromuscular dysplasia, these are both systolic, diastolic epigastric bruits, versus a AAA or an abdominal aortic aneurysm is only going to be a systolic bruit. Clinical presentation for fibromuscular dysplasia would be resistant hypertension from the renal artery involvement. There can be cerebral vascular diseases in fibromuscular dysplasia with symptoms of brain ischemia like amaurosis fuga. There could be Horner syndrome or transient ischemic attacks, as well as strokes with cerebrovascular symptoms of fibromuscular dysplasia. And these can also involve the iliac arteries, the subclavian, and the visceral arteries. The diagnostic and follow-up is, if non-invasive testing, that's going to be preferred. So CT, angio, and duplex ultrasound, those are all non-invasive tests that are preferred. Also a catheter-based digital subclavian arteriography for patients that have inconclusive or non-invasive testing. So if the non-invasive test, the CT, the angio, the duplex ultrasound comes back inconclusive, then you can go ahead and move a step further and do a catheter-based arteriography. And then medically treated patients need follow-up blood pressure monitoring, as well as creatinine levels done every 3 to 4 months, with a renal ultrasound done every 6 to 12 months. A stenosis of the renal artery is going to be common in patients that are older than 50 years of age, especially males, and it's more common on the left side. The bruit may be heard, but it is unrelated to stenosis. Remember that the left kidney, the actual irrigation of that kidney is shaped in the letter L. There's a 90-degree angle in there, so it's not a very easily flowing irrigated kidney. So as you get older, that artery tends to be more stenotic, and there's more chances of having a totally physiological type of renal artery stenosis that's unrelated to pathological renal artery stenosis. In primary hyperaldosteronism, there's also going to be an increase in aldosterone, and there's going to be a decrease in renin, and that's going to lead to an aldosterone-renin ratio that's more than 20. So high aldo with low renin. That's seen in primary hyperaldosteronism, because aldosterone is primarily increased, right? High aldosterone means sodium retention, means water retention, means that the renin is going to be negatively inhibited. So low renin, high aldo. Next one would be coarctation of the aorta. So in coarctation of the aorta, the pathology here is that there's a thickening of the tunica media of the aortic arch near the ductus arteriosus. Sometimes they ask that, the thickening of the tunica media. And clinical features would be like hypertension in the upper extremities, as well as a decreased perfusion to the lower extremities. There could be a decrease in post-ductal oxygen saturation, as well as a decrease in femoral pulses. And there's also lower extremity claudication in adults. Heart failure is also seen with irritability and poor feeding, as well as diaphoresis. There can be cardiogenic shock in infants with coarctation of the aorta, as well as palpable pulsations in the intercostal vessels in adults. So that's a big one that they like to ask, is they'll have, you can feel their pulse between their ribs. There can also be rib notching. That's a big one, but it's kind of obvious for coarctation of the aorta. There's a systolic ejection murmur heard at the intrascapular area. Patient may have an increased risk of shock. There could be a delayed capillary refill that's more than 3 seconds, as well as metabolic acidosis and decrease in renal perfusion, as well as decrease in urine output. A late presentation of an aortic coarctation would be an asymptomatic patient that has hypertension. That's the most common presentation in aortic coarctation. They can have chest pain, there can be claudication, headaches, epistaxis. They can be heart failure and aortic dissection in severe cases. So for aortic coarctation on exam, you'll see brachial femoral delay. There'll be an upper extremity hypertension with lower extremity hypotension. And there's a continuous cardiac murmur from large collaterals. Diagnostic studies on EKG, they'll show a left ventricular hypertrophy, and that's associated with an increased voltage of the QRS complex, as well as ST wave and T wave changes in left precordial leads, because this is affecting the left side of the heart in aortic coarctation. On chest x-ray, we said the rib notching of the third and eighth ribs, the third through the eighth ribs, from an enlargement of the intercostal arteries. There's the number 3 sign from an aortic indentation. So the aorta can have an indentation there, so it looks like a number 3 on chest x-ray. And on echo is going to be the diagnostic confirmation. Treatment for a coarctation would be to actually balloon angioplasty it with or without a stent. So you're going to want to pop open that balloon and increase the diameter lumen. in that coarctation. That's the treatment of choice. And associated conditions with aortic coarctation would be like a bicuspid aortic valve, ventricular septal defects, and Turner syndrome. So remember, Turner syndrome with aortic coarctation. That's a common one that they like to ask. All patients with that are young with systemic hypertension should be evaluated for a coarctation of the aorta with simultaneous palpation of brachial and femoral pulses to assess for brachial femoral delay. You want to check supine bilateral arms, so the brachial and prone right and left on the leg, popliteal. So you want to check your brachial arteries and your popliteal arteries to assess for a differential in pressure. All right, moving on. We have HIT, which is a heparin-induced thrombocytopenia. So there's two types of HITs, of heparin-induced thrombocytopenia. Type 1 is a non-immune direct effect of heparin on platelet activation, and that's usually present within the first 2 days of heparin exposure, so that's pretty fast. The platelet count then is going to normalize with continued heparin therapy, and there are no clinical consequences with type 1 heparin-induced thrombocytopenia. Versus type 2 heparin-induced thrombocytopenia, that's more serious. It's immune-mediated due to antibodies to platelet factor 4. So if you ever see platelet factor 4, that's HIT type 2. And that's a platelet factor 4 bound to heparin that's going to lead to platelet aggregation, thrombocytopenia, and thrombosis of both arterial and venous supplies, as well as platelet counts are going to usually drop more than 50% of baseline with a nadir of 30,000 to 60,000 units. And it presents 5 to 10 days after the initiation of heparin. So if you see anyone who started heparin and then started having symptoms a week later, think type 2, because type 1 is usually present within the first 2 days of heparin exposure. Type 1 is not that bad. Type 2 is serious. So this presents 5 to 10 days after the initiation of heparin therapy, and that can lead to life-threatening consequences such as limb ischemia and strokes. All right, moving on, just a recap. This is a step 1 recap at cytochrome P450 inducers and inhibitors. So drugs and supplements that affect warfarin metabolism. So specifically when you're thinking P450 inhibitors in the step 2 exam, it's more towards the effects of warfarin. So here your CYP450 inhibitors that increase warfarin effect and increase the risk of bleeding versus the cytochrome P450 inducers are going to decrease the warfarin effect and decrease the efficacy. So remember, cytochrome P450, if it revs up P450, you're revving up metabolism, which metabolizes the drug and makes it less effective, versus P450 inhibitors basically inhibit the cytochrome, making the drug more toxic. So with that in mind, the inhibitors are going to be like acetaminophen, NSAIDs, antibiotics and antifungals like metronidazole, amiodarone. Remember amiodarone, check your PFTs, LFTs, and TFTs. That's why. Cimetidine is an H2 blocker that can that inhibit the cytochrome P450. Cranberry juice, ginkgo biloba, as well as vitamin E. Omeprazole, thyroid hormone, and SSRIs like fluoxetine. All those are going to basically, those are all slowly metabolized drugs, and all slowly metabolized drugs are basically work at the liver. So any drugs that work in the liver are going to inhibit the P450 if it's too toxic. And that's going to increase the effects of warfarin because the enzyme's not working as hard. Versus the inducers, here you have carbamazepine, ginseng, green vegetables like spinach, oral contraceptives, phenobarbital, rifampin. Remember, rifampin revs up P450, and then also St. John's wort. Acetaminophen, if taken at significantly higher doses, more than 2 grams a day, for more than a week, can actually significantly enhance the effects of warfarin. So be careful giving acetaminophen when somebody's on warfarin. Now, digitalis toxicity, same deal here, but in a different way. Digitalis toxicity causes atrial tachycardia with an AV block, can cause arrhythmia specific to a digitalis toxicity, and digitalis is responsible for an increased ectopy in the atria and the ventricles, and that can lead to atrial tachycardia. Then atrial tachycardia can be differentiated from atrial flutter because of the heart rate differences. There's a 150 to 250 beats per minute in atrial tachycardia versus 250 to 350 beats per minute in atrial flutter. Remember, atrial flutter can lead to a fibrillation. Now, P waves present in digitalis toxicity, but they're different than normal P waves. They're closer to the ectopic focus of an SA node, and it more resembles an ectopic P wave than a normal P wave. Also, digitalis causes an increase in vagal tone, and that causes an AV block. And also, a multifocal atrial tachycardia can be rarely associated with digitalis toxicity, but it is more commonly a consequence of pulmonary disease. So symptoms of digoxin toxicity or digitalis toxicity would be life-threatening arrhythmias. In the GI, they can cause anorexia, nausea, vomiting, and abdominal pain. And in neurological symptoms would be fatigue, confusion, weakness, and color vision changes. So that's a big one for digoxin toxicity, is the difference in seeing colors. Amiodarone or verapamil, as well as quinidine and propafenone, all increase the levels of digoxin, and they can lead to a toxicity as well. So amiodarone, remember, check your TFTs, PFTs, LFTs. Amiodarone is a very toxic drug, so that can cause digoxin toxicity. Verapamil, that's a calcium channel blocker. I believe it's a non-dihydropteridine calcium channel blocker. And quinidine and propafenone increases the serum levels of digoxin. Okay, acute toxicity has predominant GI symptoms, and chronic has predominant neurological symptoms. So remember that chronically you can get altered mental status and confusion, weakness, and visual color changes if it's a chronic toxicity, versus a acute toxicity is going to be GI symptoms. That's pretty easy because everything else causes GI symptoms of anorexia, nausea, vomiting, and abdominal pain. So why not digoxin toxicity? And it's acute. It's recommended that digoxin dose be decreased by 25 to 50% when initiating amiodarone because of the amiodarone causing digoxin toxicity. And you have to closely monitor those that are on digoxin. You have to do that weekly, if not for several weeks. Amiodarone toxicity, the major side effects of amiodarone toxicity are going to be cardiac toxicity, pulmonary toxic, endocrine toxic, GI, hepatic, ocular, dermatological, neurological, everything. So cardiac complications of amiodarone would be like sinus bradycardia. It can cause heart block. There can be risks of proarrhythmias. There can be prolongations of the QT wave. And because of that, there's an increased risk of torsades de pointes. Pulmonary causes of amiodarone toxicity would be like chronic interstitial pneumonitis, such as cough, fever, dyspnea, pulmonary infiltrates. That's the most common. Endocrine causes, it can cause hypo or hyperthyroidism. In the GI and in the liver, it can cause elevated transaminases as well as hepatitis. That's your LFTs, TFTs for endocrine, PFTs, pulmonary. Ocular would be corneal microdeposits and optic neuropathy. Dermatological causes of amiodarone toxicity would be that blue-gray skin discoloration. And neurological causes of amiodarone toxicity would cause peripheral neuropathy. The use of amiodarone can cause serious ventricular arrhythmias in patients with coronary artery disease and ischemic cardiomyopathy, rhythm control and atrial fibrillation, and an underlying left ventricular dysfunction. 50% of patients on long-term amiodarone will develop side effects. So remember, long-term are going to be your CNS, altered mental status kind of things, and acute toxicity is kind of like digoxin toxicity, your GI symptoms. But most common are going to be your pulmonary, endocrine, and GI hepatic causes. Now, pulmonary toxicity, the serious adverse effects, we already said that. It can also present with ARDS, and it correlates with a total accumulative dose rather than a serum drug level, and that usually occurs months to several years after initiating the drug therapy. So here, it's a chronic cause. It has nothing to do with the dosages. It has to do with the chronicity of how long you've been taking amiodarone when it comes to pulmonary toxicity. A baseline chest x-ray and pulmonary function test prior to therapy initiation should be done to find out if you're already at risk of having any type of cardiopulmonary problems. And long-term development of signs and symptoms like cough, fever, dyspnea, suggestive of pulmonary toxicity. Abnormal liver function tests discontinue if there's more than twofold. So if you already have high liver function tests, you already have a liver failure or something of that nature, then you shouldn't even think about giving amiodarone. As well as corneal deposits, as a drug screening is secreted in the lacrimal glands. The vision is usually unaffected and doesn't require drug discontinuation. And you want to do the routine monitoring for the thyroid function test before starting the drug, the amiodarone, and 3 to 4 month intervals, as well as liver function tests like we said earlier. And also suspicious of pulmonary symptoms, you want to obviously get a chest x-ray and pulmonary function tests. For visual symptoms, you want to do a thorough ophthalmological examination. So it's all pretty obvious stuff before you give this drug. If the drug is known to give you thyroid problems, check your thyroid before giving it. If it's known to give pulmonary problems, check pulmonary function tests, check a chest x-ray. Because if it's known to cause liver failure, check your liver enzymes before starting amiodarone. All right, serotonin syndrome. So clinical features of serotonin syndrome would be divided into common drug reactions, signs and symptoms, and treatment. So here, common drug interactions with that causes serotonin syndrome would be like selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, MAOIs, TCAs, tramadol, linezolid, serotonin receptor blockers like ondansetron, and triptans like your sumatriptan. Those are all common drug interactions that can cause serotonin syndrome. Signs and symptoms of serotonin syndrome would be your hyperthermia, autonomic instability like tachycardia, hypertension, diaphoresis, there can be confusion, agitation, tremors, hyperreflexia, akathisia, muscle rigidity, inducible or spontaneous clonus, and that clonus could be either ocular or peripheral. There could be dry mucous membranes, increased bowel sounds, there could be flushed skin and dilated pupils. And the treatment here is to discontinue the serotonergic drug. You want to give benzodiazepines for sedation, agitation, and blood pressure elevation. Supportive care, like oxygen and fluids. Cyproheptadine is going to be preferred when supportive measures fail. And critically ill patients are going to require intubation in intensive care unit. All right. What are some of the adverse effects of phosphodiesterase 5 inhibitors, or PDE5? So phosphodiesterase 5 inhibitors can cause cardiovascular problems like hypotension, especially with nitrates and alpha blockers. It can cause ocular problems like blue discoloration in vision, and as well as non-arteritic anterior ischemic optic neuropathies. And the GU can cause priapism. That's the big one for the PDE5 inhibitors, priapism, and other things like flushing, headaches, and hearing loss. If alpha blockers are going to be used alongside a PDE5 inhibitor, then they should be used with a lot of caution. Minimum effective dose of both drugs should be given with careful dose titration. It should be taken 4 hours apart. So if you have to give both alpha blockers and a PDE5, then not only do you have to give them the lowest dose possible, you should also separate them. They should be taken at 4 hour intervals or 4 hours apart. All antihypertensives should be used with caution with a PDE5 inhibitor. Diabetic retinopathy is not a contraindication for PDE5 inhibitors. PDE5 inhibitors can cause temporary bluish discoloration due to cross-reactivity with the PDE6 inhibitors, which involve color vision in the retina. There's non-arthritic optic neuropathy, and that's noted with the PDE5 inhibitors, and but its use and relationship is unclear. So PDE5 inhibitors have been found to decrease symptoms of diabetic peripheral neuropathy in peripheral artery disease. So next topic is coriponmanol. So characteristic findings of coriponmanol are COPD, that's the most common etiology, as well as interstitial lung disease, pulmonary vascular diseases like thromboembolic diseases, as well as obstructive sleep apnea. Symptoms for coriponmanol would be dyspnea on exertion, fatigue, lethargy, as well as exertional syncope due to a decrease in cardiac output. Exertional angina due to an increase in myocardial demand. On exam, there could be peripheral edema. There could be an increase in jugular venous pressure with prominent A waves, a loud S2, right-sided heaves, and pulsatile liver from congestion, as well as tricuspid regurgitation murmurs. On imaging on the EKG, you can see a partial or complete right bundle branch block with coriponmanol, as well as a right axis deviation, right ventricular hypertrophy, and right atrial enlargement. So if you ever see right hypertrophy or right axis deviation, anything towards the right, think of coriponmanol as a good differential. Echocardiogram, pulmonary hypertension, dilated right ventricle, and tricuspid regurgitation. And on right heart catheterization, that's going to be the gold standard for the diagnostic, showing a right ventricular dysfunction, pulmonary hypertension, and no signs of left heart disease. Okay, so signs and symptoms, occasionally ascites or pleural effusion with the right ventricular third heart sound, a loud P2, and that would be your pulmonic sound, anorexia, and abdominal pain due to hepatic congestion. Right heart catheterization is the definitive diagnosis for coriponmanol, and that can be made using a right heart catheterization showing elevated pulmonary artery systolic pressures of more than 25 millimeters of mercury. All right, moving on, we have shock. Shocks, the hypodynamic measurements of shock. So here on the right atrial pressures or preload, a normal pressure would be a mean of 4 millimeters of mercury. So in hypovolemic shock, right atrial pressures are going to be decreased. Cardiogenic shock, the right atrial pressure are going to be increased. And in septic shock, right atrial pressure is going to be normal or maybe slightly decreased. So again, in right atrial pressures or preload, here you'll have in hypovolemic shock low pressure because there's low volume. If there's cardiogenic shock, it'll be increased because the heart's not moving anywhere. It just keeps filling, so the pressure's increased. And in septic shock, that's just normal. Normal arterial pressures. For pulmonary capillary wedge pressure, in hypovolemic shock, the pulmonary capillary wedge pressure is going to be decreased, again, because there's low volume. Cardiogenic shock, the pulmonary capillary wedge pressure is going to be increased, and again, in septic shock, it's going to be normal or slightly decreased. So here, they're both pulmonary capillary wedge pressure and right atrial pressures are both preload problems, so they both look the same in terms of the types of shocks. Now, your cardiac index in hypovolemic shock is decreased. Again, there's low volume. But in cardiogenic shock, the cardiac index is extremely low. And in septic shock, the cardiac index is high. The systemic vascular resistance or afterload is going to be high in hypovolemic shock. It's going to be high in cardiogenic shock, and it's going to be low in septic shock. And the mixed venous oxygen saturation is going to be low in hypovolemic shock. it's going to be low in cardiogenic shock, and it's going to be increased in septic shock. So in hypovolemic shock, the right side of the heart is going to be decreased. Cardiac index is going to be decreased, but the afterload or systemic vascular resistance is going to be increased, and the mixed venous oxygen saturation is going to be low. Versus cardiogenic shock, right atrial pressures are going to be increased. So both preloads are going to be increased in pulmonary capillary wedge pressure and right atrial pressure. The cardiac index in cardiogenic shock is going to be low because the shock is associated with the heart, cardiogenic. And then systemic vascular resistance is going to increase due to compensation, and that's going to lead to an increase in afterload. And mixed venous oxygen saturation is going to be low. And in septic shock, both preloads are going to be normal. Cardiac index or pump function is going to be high. And systemic vascular resistance is going to be low because of the vasodilatory effects of septic shock, and the mixed venous oxygen saturation is high. So hypovolemic shock. So you want to consider hypovolemia in any patient with hemorrhage unless otherwise proved. Severe hemorrhage is going to lead to a decrease in venous return, and that decreased venous return is going to lead to an end diastolic volume that's decreased. That's going to in turn lead to a decrease in cardiac output and an increase in sympathetic activity, which is going to increase venous capacitance vessels, and it's going to improve venous return, causing there to be flat neck veins because of the low volume. If there's a positive pressure mechanical ventilation that's given without correction of intravascular volume loss, it's going to increase intrathoracic pressure, and that's going to lead to an increase in right atrial pressure. That increase in right atrial pressure is going to decrease systemic venous return to the heart, and that's going to lead to an acute circulatory failure, which ultimately leads to death. Additionally, sedative medications are given prior to intubation also relax venous capacitance vessels, and they themselves can cause circulatory failure by acutely decreasing venous return in a hypovolemic patient. So be careful with that. That could be a test question. That in a hypovolemic patient, by giving them sedative drugs for intubation, if intubation is required, that drug for intubation usually also decreases blood pressure and venous return to the heart, making the hypovolemic symptoms even worse. And they may not respond well to fluid resuscitation. Next would be septic shock. So in septic shock, there's a hyperdynamic phase and a hypodynamic phase. So in your hyperdynamic phase, there's a decrease in systemic venous return, a decrease in blood pressure, and an increase in heart rate and cardiac output. That's why in hyperdynamic septic shock, the patient's going to feel warm. Versus hypodynamic phases of septic shock, that's going to increase systemic vascular resistance, decreasing cardiac output, and that causes a very bad deterioration, leading to a cold shock. So first they're warm, and then ultimately end up being cold with septic shock. Exertional heat stroke. The risk factors here would be strenuous activity during the hot and humid weathers, dehydration and poor acclimatization. So look for like a military recruit or somebody who's starting off in the military and they just passed out and they have a temperature over 104. That's an exertional heat stroke. Lack of physical fitness, obesity, medications like anticholinergics, which already give you dry as a bone, hot as a hair kind of symptoms, antihistamines, phenothiazines, and tricyclics. Clinical manifestations, core temperatures of more than 104 degrees, like we said, immediately after collapsing, and can also have central nervous system dysfunction like altered mental status, confusion, irritability, seizures, and additional organ or tissue damage causing renal hepatic failure, DIC, acute respiratory distress syndrome. So how would you manage an exertional heat stroke? Well, you want to rapidly cool them by immersing the patient in ice water, and that's the preferred treatment. You could consider high flow cool water, but the ice water immersion is going to be the best. And both are going to be probably options. So ice water immersion. Fluid resuscitation, electrolyte correction, if they have any type of electrolyte imbalances, management of end organ complications, and there's no role for antipyretic therapy. Here you just need to rapidly cool the patient down and check their electrolytes if they are showing any type of altered mental status. So obviously get a CBC. Sweating is the main mechanism of heat dissipation. If the humidity is more than 75% or excessive ambient heat, that's going to lead to a decreased amount of sweating. So high humidity climates, the patient will sweat less because of the high humidity. So that can lead to internal heat building up instead of it dissipating. Antihistamines and anticholinergics will impair heat dissipation and cause a heat stroke. Often anhidrosis is described as a classic findings. Patients can have excessive sweating. Also, dehydration is common that leads to tachycardia, hypotension, or a hemoconcentration, which shows up as increase in hemoglobin, leukocytes, and platelet counts, and there could be an increase in BUN. And as well as leukocytosis from the severe stress involved too. So you'll have a spike in your leukocytes. Then you have non-exertional heat stroke. It's similar clinical findings to exertional heat stroke, but here the potential complications can occur in the absence of strenuous activity. This is more frequently affecting the elderly patient with significant underlying comorbidities that limit their ability to escape or cope with excessive heat. Treatment here would be evaporative cooling, like you spraying with lukewarm water while the fanned air on the patient. So you want to fan them, you want to spray them with water. This is more important than the ice immersion, which is associated with an increased mortality in the elderly population. So if they're young, dip them in ice cold water. If they're old, spray them with a spritzer of water or fan them. So you just want to take it easy and slow with elderly patients. In a cardiac myxoma, this is a tumor that's often located in the left atrium most of the time, 80% of the time. Clinical features would be constitutional symptoms like fever and weight loss, as well as Raynaud's phenomenon, and that's due to IL-6. So if they ever ask, what is the mechanism behind the Raynaud's phenomenon in general, and it's because of an IL-6. Cardiovascular complications of cardiac myxomas would be like valvular abnormalities, that tumor impeding the function of the valve, and that most commonly is due to a mitral cause. Heart failure due to anatomic obstruction, myocardial invasion causing arrhythmias, heart block, or pericardial effusion. Embolization is another feature of a cardiac myxoma, and lung invasion causing respiratory symptoms, and that can mimic bronchiogenic carcinoma, so be careful. The diagnostic management for a cardiac myxoma is echocardiogram and prompt surgical resection. Transesophageal echo is the most sensitive, though transthoracic echo is going to be the most adequate. So hyperthyroidism is our next topic. And in hyperthyroidism, the general manifestations are going to be anxiety symptoms, insomnia, palpitations, heat intolerance. There could be an increase in perspiration, weight loss with a decrease in appetite, as well as a goiter. And on physical exam, yes, they do have hypertension, tremors involving the fingers and the hands, hyperreflexia, and proximal muscle weakness, as well as lid lag and atrial fibrillation. Hyperthyroidism is going to increase beta adrenergic receptors stimulation, and that's going to increase the sympathetic activity. So you want to treat hyperthyroidism with a beta blocker. Beta blockers like propranolol or atenolol, and those should be started in patients with hyperthyroidism as soon as it is diagnosed and continued until they become euthyroid with thionamides, radioiodine, or with surgery. Scleroderma renal crisis. This is a malignant hypertension that causes headache, blurry vision, nausea, and an acute renal injury without previous kidney injury. This is a sclerodermal renal crisis. So there's an increase in creatinine and BUN because of the kidney injury in the setting of systemic sclerosis or scleroderma, and that leads to sclerodermal renal crisis. That affects 20% of patients with diffuse cutaneous systemic sclerosis within the first 5 years of getting diagnosed. The mechanism of action here is that they have an increase in vascular permeability, there's an activation of the coagulation cascade, and an increase in renin secretion. Urinalysis can be normal and shows mild proteinuria. Peripheral blood smear can show a microangiopathic hemolytic anemia that's similar to HUS or TTP, with DIC and fragmented red blood cells like schistocytes and a thrombocytopenia. There can be Burr cells, which are your echinocytes, and those are like your serrated edges, so it's like a ball with spikes, and that's found in liver disease or end-stage renal disease. Howell-Jolly bodies, these are found with a history of a splenectomy or functional asplenia. So patients without a spleen, think Howell-Jolly bodies is what you'll see on a blood smear. Spur cells are irregularly spaced projections, and that's also caused in liver disease. It's similar to Burr cells, spur cells and Burr cells, and they're both due to liver disease. So, and then target cells, these are found in hemoglobinopathies like thalassemias or chronic liver diseases or chronic lung diseases, especially obstructive lung diseases and obstructive liver diseases. So that's the end of cardiology and internal medicine. Next up is pediatric cardiology. So in pediatric cardiology, it starts off with breath holding spells. And here you'll have either a cyanotic or pallid breath holding spell. Cyanotic breath holding spells are going to be crying followed by a breath holding, and that's going to cause cyanosis and loss of consciousness, versus a pallid breath holding spell is going to be minor trauma followed by breath holding, pallor, diaphoresis, and then finally loss of consciousness. Breath holding spells are benign and parents should be reassured. Common in the 6 months of age to 2 years of age, and usually it stops by when they turn 5 years old, and the child usually starts developing normally. It may represent a variant of a vasovagal syncope, and some may develop vasovagal syncope later on in life. Iron deficiency anemia can also cause the breath holding spells, and supplements are then given if the anemia is found. And in the pallid form of the breath holding spell, there may be confusion and sleepiness within a few minutes. So if they say sleepiness or confusion, that's a pallid breath holding spell. If they have recurrent or prolonged breath holding spells, or if they have a family history of cardiac disease, syncope, or sudden death, then you have to do an EKG. You want to do an echo if there is a murmur, and if they have port growth or diaphoresis, as well as dyspnea with feeding and dyspnea with activity. You need to do a murmur, echo for a murmur. Next one would be Turner syndrome. Turner syndrome is associated with a coarctation of the aorta, and that's a continuous murmur heard all over the chest due to the development of the collaterals between hypertensive and hypoperfused vessels. There's going to be rib notching, like we said earlier, and that's due to dilation of collateral chest wall vessels. Congenital heart defects, there's normal fetal circulation. The blood is shunted away from the lungs by a PDA, and systemic circulation is going to mainly rely on the right ventricle. The right ventricle is going to be larger than the left, and that's normal in newborns. And on EKG, it's normal to have right axis deviation in that case, with R waves in the precordial leads, which are your leads V1 through V3 on EKG. It can also be a PDA-dependent congenital heart disease, and these consist of coarctation of the aorta, detransposition of the great arteries, also hypoplastic left heart syndrome, total anomalous pulmonary venous connection, and tricuspid atresia. And if hypoxia fails to improve with inhaled oxygenation, then that's most likely going to be a congenital heart disease. Oxygen saturation of 70 to 90% if there's central cyanosis, and then that's going to lead to a cyanotic heart disease. Normally, the PDA is going to constrict and become non-functional around day 3 of life, and there's a closure in the PDA is going to be dependent on congenital heart defects, and that can lead on either severe hypoxia, shock, or lactic acidosis. You want to keep open the PDA with a PGE1 until surgery can be performed. So PGE1 is a prostaglandin E1 that maintains it open. Excessive inspired oxygen and indomethacin should be avoided, because remember that indomethacin ends the patency and constricts the ductus arteriosus. Cyanotic heart diseases in newborns are basically all the T's. So you have transposition of the great vessels, tetralogy of Fallot, tricuspid atresia, truncus arteriosus, and total anomalous pulmonary venous return. So for transposition of the great vessels, on exam they'll show a single S2 because they've been transpositioned, they've been switched around. So you'll just see a single S2 with or without the murmur of a VSD. On X-ray, you'll see that classic egg on a string appearance, and it's the heart, which shows a narrow mediastinum. That's your egg on a string appearance for transposition of the great vessels. For tetralogy of Fallot, on exam, there's going to be a harsh pulmonic stenosis murmur as well as a VSD, and you have that boot-shaped heart, and that boot-shaped heart is because of a right ventricular hypertrophy. Tricuspid atresia will show a single S2 as well as a VSD murmur, and here on X-ray they'll have minimal pulmonary blood flow with a tricuspid atresia. In truncus arteriosus, again a single S2, but this is a systolic ejection murmur which has increased flow through that truncal valve. So on X-ray you'll see increased pulmonary blood flow as well as increased pulmonary edema. And finally, in total anomalous pulmonary venous return, that will show with severe cyanosis and respiratory distress. And on X-rays, they'll have pulmonary edema and the snowman sign, which is an enlarged supracardiac veins and a superior vena cava as well. That's total anomalous pulmonary venous return. Okay, so transposition of the great vessels, most common neonatal cyanotic heart disease, and it's mostly present within 24 hours of birth. So if they ask the question of this child came out cyanotic, what congenital heart diseases you most likely have, and its transposition is going to be the most common. It shows up with a single S2 because pulmonary component is missing as it lies behind the aorta. A PDA or a VSD, both can cause the murmur, or a patent foraminal valley. But the patent foraminal valley will not have a murmur, and that's needed for mixing of oxygenated to deoxygenated blood after birth. Remember that inadequate mixing is going to cause a rapid and severe cyanosis as well as pulmonary edema, and they can die if the shunt isn't developed. So an emergency atrial septostomy is needed when you have transposition. If transposition of the great vessels is, however, suspected, then prostaglandins should be started immediately to maintain the mixing. Remember, prostaglandins keep the PDA open, and that mixing and echo should be obtained. Next, we have tricuspid atresia. Tricuspid atresia, since it starts with the letter T, gives you cyanosis. There's a lack of communication between the right heart chambers, and that leads to a hypoplastic right ventricle with a diminished right ventricle force on EKG. The lack of the right ventricle filling and pulmonary outflow tract is going to cause an underdevelopment of the pulmonary valve, and also an underdevelopment of the pulmonary artery, which causes a decrease in pulmonary markings on chest X-ray, and you'll need an ASD or a VSD for those patients to survive. So because it's shunted towards the left, the EKG will show left axis deviation and a small or absent R wave in the precordial leads. They'll also have a tall peaked P wave because of the ASD, causing an increase in blood flow to the right atrium and a subsequent enlargement of that right atrium. The cause of a tricuspid atresia is unknown, but it can occur with any congenital heart defect with a family history of congenital heart diseases. And treatment for tricuspid atresia is surgical repair, and that can improve within 10 years, leading to 80% of survival. Lack of repair will cause death within a year of life. Moving on, we have complete AV canal defects. That's the most common congenital heart defect in Down syndrome. This is an underdeveloped atrioventricular valve, so they can also have ASDs and VSDs. They present with diaphoresis, dyspnea, with feeding, and that's usually present at 6 weeks when the pulmonary vascular resistance is going to fall. And on auscultation, you'll hear a loud S2, and that loud S2 is due to pulmonary hypertension. There's also a systolic ejection murmur from increased flow across the pulmonary valve from the left to the right shunt across an ASD. There's also a holosystolic murmur of a VSD, which may be soft or absent if the defect is large enough. So remember, if there is a VSD and you can hear the murmur, the aperture of that VSD, the hole, is going to be small, because the smaller the hole, the smaller the aperture, the more pressure goes through that hole, and that increase in pressure causes a sound to occur. Kind of like when you're whistling, you have to pucker your lips so that a sound can occur. But if the hole is bigger, or you open your mouth, it's pretty hard to whistle at that point. So the louder the aperture, the louder the hole, then the more blood flow, the less amount of pressure, which means the less likely you will hear a murmur. So loud VSDs means that the hole is small. Quiet VSDs means that the hole is big. On chest x-ray, including pulmonary markings and cardiomegaly from excessive pulmonary blood flow and a biventricular volume overload. So we just see pulmonary markings on chest x-ray. All right, VSD, this can range from small VSDs, asymptomatic, to large VSDs causing left to right shunts. There's failure to thrive and easy fatigability, as well as heart failure. A VSD can cause a pansystolic murmur at the left lower sternal border and a diastolic rumble at the apex due to an increase in blood flow across that mitral valve, leading to an echo that's required to evaluate the size and the location of the defect. The treatment here for a VSD depends on the size of the defect and the severity of the symptoms. So generally, a combination of medications like diuretics and a transcatheter or surgical closure is ideally done before development of an Eisenmenger syndrome. So you want to do this before you get to that right to left shunt. That left to right shunt becoming a hypertrophic right ventricle, leading to a left to right shunt and developing Eisenmenger syndrome. So you want to do that before that develops. There's a small VSD closure in 75% of children, and small VSDs close by age 2 years of age with no long-term sequelae. Ebstein's anomaly is a malformed tricuspid valve into the right ventricle, leading to a droopy tricuspid valve, and that droopy tricuspid valve will cause severe tricuspid regurgitation, and that leads to a right atrial enlargement, and that right atrial enlargement will then cause tall P waves and right axis deviation. Auscultation is your triple or quadruple gallop, and that's a widely split S1 and an S2 plus a loud S3 or S4. So that's that triple or quadruple gallop. And a holosystolic or early systolic murmur at the left lower sternal border. And on chest x-ray, there's an extreme cardiomegaly from heart failure. Next one is tetralogy of Fallot. In tetralogy of Fallot, they present with severe obstruction from pulmonary atresia with profound cyanosis and hypoxemia in the neonatal period. There's also moderate obstruction causing hypercyanotic or TET spells in infancy or childhood. So if you see those TET spells happening, That's a moderate obstruction. And then minimal obstruction would be heart failure in childhood or adulthood. But severe obstruction is the profound cyanosis in the neonatal period. But the TET spells, which are usually the ones that they test on, are due to a moderate obstruction. Physical exam, they'll present, patients with tetralogy of Fallot will present with harsh systolic ejection murmurs at the left upper sternal border and a single S2. And on chest x-ray, there's a boot-shaped heart. The management of a tetralogy of Fallot would be if they're hypercyanotic TET spells, you want to put them in a knee to chest position or inhaled oxygen, and then surgery before the age of 6 years old. Patients with mild obstruction can develop hypercyanotic or TET spells because the dramatic infundibular spasms occur during exertion or agitation. And that situation is going to be dangerous, so they should be placed in the knee-chest position immediately. What that does is that it increases systemic venous return, including pulmonary blood flow, and it improves the symptoms of the cyanosis. Oxygen then should be given to stimulate pulmonary vasodilation as well as systemic vasoconstriction. Morphine is also given to relax the patient and give IV fluids to improve right ventricular filling as well as pulmonary blood flow. Decreased vascular markings are going to be seen on chest x-ray due to pulmonary outflow tract obstructions, and a boot-shaped heart is going to often develop later on, but they have right axis deviation as in a normal newborn. Remember, in a newborn, they have, since it's a right heart, the right heart is working most, that right heart is going to be more hypertrophy than the left. So normally a newborn will have right axis deviation on an EKG. Elective surgical repair is performed before 6 months of age to decrease morbidity and mortality from outgrowing the right ventricular outflow tract. Okay, next one would be total anomalous pulmonary venous return. All pulmonary veins are going to drain into the superior vena cava. From there, it's going to go into the right atrium and to the right ventricle, and that ventricle will cause a ventricular enlargement. This will then cause a right axis deviation, and that's normal. And this is going to increase the markings on chest x-ray to increase pulmonary blood flow. Truncus arteriosus strongly is associated with DiGeorge syndrome. So if you see DiGeorge syndromes or signs of DiGeorge syndrome, remember truncus arteriosus. And that's normal on EKG. They'll have a normal EKG, and the chest x-ray is going to show cardiomegaly and increased pulmonary vascular markings from heart failure and pulmonary overcirculation. A PDA that's associated with congenital rubella syndrome and something called CHAR syndrome. CHAR syndrome is going to affect the face, the heart, and the limbs. The PDA is going to be a continuous murmur because of blood flow that's going from the aorta to the pulmonary artery, and that's due to the pressure in the aorta always being more than the pressure in the pulmonary artery. So it's a continuous machine-like murmur, as they always say. Clinical findings would depend on the size and the length of the PDA. A small PDA is usually asymptomatic, and it may show mild accentuated peripheral pulses. Pediatric viral myocarditis, its etiology is either through a Coxsackie B virus infection or adenovirus infection. Clinically, they present with a viral prodrome. They'll have heart failure, dyspnea, syncope, tachycardia, nausea, vomiting, hepatomegaly. So all these myocarditis signs and symptoms, but in a child. So that would be a viral myocarditis. On diagnostic studies, the chest x-ray is going to show cardiomegaly because it is a myocarditis, and as well as pulmonary edema. On EKG, there could be sinus tachycardia, and on echocardiogram, you'll see a decrease in ejection fraction as well as diffuse hypokinesis. Endomyocardial biopsy is going to be the gold standard for pediatric viral myocarditis, and that'll show inflammatory infiltrates in the myocardium with necrosis of the myocytes. Prognosis here, in newborns, they have around 75% mortality versus older infants and children have around 25% mortality. So the older they are, the less the mortality risk is. And outcome of survivors that they usually fully recover within 2 to 3 months. That's the majority of the time they fully recover within 3 months. And only 33% progress to dilated cardiomyopathy and chronic heart failure. So the myocarditis is potentially lethal, and the causes here, again, are viral or autoimmune mediated or toxin mediated. The pathogenesis really depends on whether it's a direct viral injury and an autoimmune inflammation that leads to the myocyte necrosis, and that's going to impair systolic and diastolic function. So more severe, it's more severe in newborns, and that can cause death because of an immature myocardium, and that's less adaptable to acute insults. So because they're so new, they don't have the capacity to adjust and change to their environment as easily as an older heart would. So symptoms overlap with other pediatric illnesses, and this could be like a misdiagnosed asthma or pneumonia, so be careful. A holosystolic murmur can be heard secondary to a dilated cardiomyopathy, and that leads to mitral regurg. A chest x-ray in myocarditis can be a healthy infant less than a year with a transverse cardiothoracic ratio that's less than 60%, and a healthy more than 1 year old at less than 50%. Okay, the EKG is going to show normal, non-specific T-wave changes, so here an echo is the best choice. Viral studies should be sent to identify the offending pathogens, and treatment would be supportive, such as diuretics and inotropes, and then affected children should be monitored in the ICU due to a risk of shock and fatal arrhythmias. So that could be a question. This child presents with myocarditis signs. He recently has an infection. He has a fever and myocarditis. You're thinking viral myocarditis, but they're asking you, what do you do next? And it would be to monitor the patient in the ICU to assess risks of shock or fatal arrhythmias. Acute rheumatic fever also occurs after 2 to 4 weeks of a group A strep infection, and it's uncommon in children less than 3 years with fever, epithelial cell attachment sites in the throat. Now, Kawasaki's disease. Kawasaki's disease is a fever that has more than 5 days, so more than a week of fever, plus 4 of the following 5 criteria. So a week of fever with bilateral non-exudative conjunctivitis, or mucositis with injection of and fissured lips, injected pharynx, or a strawberry tongue, cervical lymphadenopathy with at least 1 lymph node being more than 1.5 centimeters in diameter. It could be a week of fever with erythematous polymorphous rash, or extremity changes like edema and erythema. And the treatment here is to give them aspirin. It's the only case in a child where you give them aspirin. And it's okay to give a child aspirin when it's Kawasaki's disease. Aspirin plus IV immunoglobulin. And complications of Kawasaki's would be coronary artery aneurysms, they do like to ask that, as well as myocardial infarction and ischemia. So the diagnosis of Kawasaki's disease is actually clinical. Irritability is also a common feature, typically in children less than 5 years of age, but it can occur late in late childhood as well. The treatment should be started within 10 days of fever onset to prevent cardiac complications. So you want to start giving them treatment if you're seeing like the rash and the mucositis and the extremity changes, lymph node, enlarged lymph nodes with more than a week of fever. Immediately start treatment to prevent those cardiac complications. So a baseline echo is given in all suspected patients, and you want to repeat that echo 6 to 8 weeks later to monitor for any types of changes that have occurred. A differential diagnosis is strep throat. There is pharyngeal exudates as well with Kawasaki's disease, so it could be strep throat. The rash is sandpaper-like, and it spares the palms and the soles. So remember that Kawasaki's disease spares the palms and the soles. DiGeorge syndrome, in DiGeorge syndrome, the pathogenesis is a chromosome 22q11 deletion. So there's a defective development of the pharyngeal pouches. And because of this, the clinical features are your catch mnemonic, the catch-22 mnemonic, which is conotrochal cardiac defects. So cardiac defects, abnormal facies, thymic aplasia or hypoplasia, a cleft palate, or hypocalcemia. Truncus arteriosus is going to be commonly associated with DiGeorge syndrome, as we said earlier, and other anomalies include tetralogy of Fallot with interrupted aortic arch and septal defects. And if DiGeorge syndrome is suspected, you want to do an immediate serum calcium and echo. The hypocalcemia is going to cause tetany, seizures, and arrhythmias, which can exacerbate underlying heart disease. Next would be stridor, the differential diagnosis of stridor in infants and children. So stridor can be found in croup, which is a laryngotracheal bronchitis. It could be found in laryngomalacia, foreign body aspiration, and vascular rings. So croup is, or laryngotracheal bronchitis is the most common from ages 6 months to 6 years. It's associated with a barky cough, with fever, rhinorrhea, and congestion. Then laryngomalacia is stridor that's most severe at ages 4 to 8 months, and that's persistent stridor that can worsen in a supine position and then improves in the prone position. Foreign body aspiration, the stridor caused by a laryngotracheal foreign body has acute onset and is associated with a moderate to severe respiratory distress. Also, vascular rings are associated with stridors, and those present before 1 year of age. And it's persistent stridor that can improve with neck extension, and it's associated with cardiac abnormalities 50% of the time. So if you see any child or any person that has stridor and the child has to extend their neck in order to breathe, that is a vascular ring. Okay, so croup is often caused by parainfluenza virus. It's the most common cause of inspiratory stridor. Remember, croup is that barking cough, the laryngotracheal bronchitis. So that's the most common cause of inspiratory stridor, and that responds to racemic epinephrine or steroids. Laryngomalacia, this is caused by an increased laxity of the supraglottic structures, and that can result in a collapse during inspiratory phases. And then finally, your vascular rings, those result from abnormal development of the aortic arch, causing tracheal, bronchial, or esophageal compression that leads to the stridor. It can lead to wheezing, coughing, dysphagia, or difficulty feeding. And they are either complete, meaning completely surrounding the trachea or the esophagus, or they can be incomplete. Common examples would be right-sided aortic arch, double aortic arch, or a pulmonary sling, or there could be an anomalous left carotid or innominate artery. And it does not improve with nebulized racemic epinephrine because it doesn't get better with steroids or bronchodilators. So that is a good indication because remember, laryngomalacia and croup, those can get better with steroids and epinephrine and bronchodilators, but in vascular rings it cannot. So also the diagnosis is going to require high indexes of suspicion confirmed with a barium contrast esophagram, and bronchoscopy is done as well, CT or MR, angiography, and the treatment here is surgery, which is the only definitive treatment in severe disease because it is a physical problem that has to be surgically corrected. And finally, cardiac surgery is our next topic. Venous valve insufficiency is the most common cause of lower extremity edema. Approximately 2% of the population is affected. Edema is aggravated after exertion throughout the day, and it's relieved with walking. There is rest with leg raising, and it's associated with cramping and heaviness. There's failure of venous valves causing the blood to pool in dependent parts like the legs, and that's going to cause an increase in capillary hydrostatic pressure, and that's then going to increase the filtration of fluid out of the capillary into the interstitial space. This will then cause a decrease in intravascular volume, which then stimulates the kidney to retain salt and water and progresses the edema. The failure of the venous valves is also going to increase pressure in the postcapillary venules, and that's going to cause capillaries to leak. And when they leak, they're going to cause a loss of fluid, plasma proteins, and red blood cells into those tissues. Red blood cell extravasation then leads to hemosiderin deposition in tissues and classic coloration of stasis dermatitis. And it mostly involves the medial leg below the knee and above the medial malleolus. Inflammation of capillaries and venules with fibrin deposition and platelet aggregation causes microvascular diseases and ultimately an ulceration. Cirrhosis, which with an X, xerosis, is the most common early finding. There's lipodermatosclerosis and ulceration, and that's found in late disease. The initial treatment for venous valve insufficiency is to elevate the legs, exercise, and compression socks. If there's no response, then you'd want to do a venous duplex ultrasound to identify any type of reflux or insufficiency. And then persistent and documented reflux will require endovenous ablation. Arterial occlusion causes pain, pallor, paresthesias, pulselessness, and coolness to the touch. A rapid deceleration or blunt chest trauma, is aortic injury. The patients suffer from rapid deceleration and blunt chest trauma or from a fall of a height of more than 10 feet are at risk of an aortic injury. Usually aortic transections, circulatory collapse, and death are immediate sequelae, and some may have incomplete or contained injury. Symptoms are usually nothing specific, but they have anxiety. There's hypertension and tachycardia that are common. Hypotension and external evidence of trauma and altered mental status is usually present as well. Management, once stabilized with airway, breathing, and circulation, is secured. You want to perform an upright chest x-ray. The chest x-ray will show a widened mediastinum as well as large LET-sized hemothorax. There's a deviation of the mediastinum to the right and also a disruption of normal aortic contour. There's depression of the left mainstem bronchus, and to confirm the diagnosis is done with a CT scan and angiography. Treatment would be antihypertensives where appropriate and surgical repair. Pulmonary contusion is our next topic, and that's the most common finding after a blunt chest trauma, and chest x-rays are going to show opacities that are caused by hemorrhage in the involved lung segments with pulmonary contusion. Esophageal rupture is rare, but the cause would be a pneumomediastinum with a pleural effusion, but it doesn't cause circulatory collapse. A myocardial rupture causes sudden death, but rarely cardiac tamponade in cases of a contained injury. Also, myocardial contusions classically cause tachycardia, a new bundle branch block, or an arrhythmia. Sternal injury is usually associated with a myocardial contusion. For diaphragmatic rupture, this presents with abdominal pain that's referred to the shoulder with shortness of breath and vomiting. On radiograph, you'll see abdominal viscera above the diaphragm with loss of a diaphragmatic contour. And bronchial rupture is rare, a pneumothorax that does not resolve with chest tube placement. You're thinking bronchial rupture, pneumomediastinum, and subcutaneous emphysema, so that popping and crackling sound when you touch the sternum. All right, so next topic is compartment syndrome. The clinical features of compartment syndrome are going to be divided into common features versus uncommon features. Some of the common features would be pain out of proportion to the injury, pain that increases on passive stretching, rapid increasing with tense swelling, and also paresthesia early on. Uncommon features of compartment syndrome would be a decrease in sensation motor weakness within hours, late paralysis, or a decrease in pulses, specifically distal pulses. Those are all uncommon. So the most common ones are going to be, they're going to present you with a pain out of proportion to the injury. Somebody who got a cut on their arm and then suddenly there's nothing to alleviate the pain because it's so painful. Reperfusion of the limbs following an arterio-occlusive ischemia for longer than 4 to 6 hours can lead to intercellular and interstitial edema, and that can also lead to an intercellular swelling. Compartment syndrome can occur when the edema causes the pressure within the muscular fascial compartment, and that goes above 30 millimeters of mercury. Or if a delta pressure, which is the diastolic pressure minus the compartment syndrome, is less than 20 to 30 millimeters of mercury, and that leads to further muscle and nerve ischemia. Compartment syndrome is more common after a traumatic injury of the extremities, especially the long bones, but it can occur post-ischemia. Treatment here, if the compartment pressures are improving and the patient can be closely observed with no rapid improvement, then you want to do a fasciotomy, and that's performed to avoid long-term complications. Bone infarction can also produce erythema and warmth, but not swelling. And recurrent embolisms can produce similar features of compartment syndrome, but there's going to be absent pulses, pallor, and lack of swelling. For a DVT, DVTs can cause calf tenderness and exacerbation of pain on passive stretching, like the Holman sign, but it is often asymptomatic, and generally it's associated with only vague aching pain. All right, next topic is an AV fistula. So AV fistulas can either be congenital or acquired. Congenital AV fistulas are either due to like a PDA, a patent ductus arteriosus, angiomas, as well as pulmonary AV fistulas and CNS AV fistulas. Acquired AV fistulas would be like trauma, iatrogenic causes like from oral catheterization, atherosclerosis from an aortal cable fistula, or cancer. So an AV fistula is going to cause a decrease in systemic vascular resistance and an increase in cardiac preload, and then an increase in cardiac output and stroke volume to maintain oxygenation of peripheral tissues. That's then going to cause a wide pulse pressure, strong peripheral artery pulsations, like brisk carotid upstrokes, and a systolic flow murmur, tachycardia, flushed extremities, and that's going to lead to left ventricular hypertrophy and a point of maximal impulse that's going to shift to the left. That then is going to cause a high output cardiac failure, and then other causes of high output cardiac failure would be like thyrotoxicosis, Paget's disease, anemia, and thiamine deficiency. So diagnose with a Doppler ultrasound, and you want to treat with surgical or you want to treat surgically for large AV fistulas. All right, so then we moving on to the topic of acute post-op mediastinitis. So this is usually a possible complication of a cardiac surgery due to intraoperative wound contamination, and it can complicate 5% of the time and become a sternotomy. It's present usually within the first 14 days post-op. They present with fever, tachycardia, chest pain, leukocytosis, and sternal wound drainages or purulent discharge. On chest x-ray, you can see a widened mediastinum with acute post-op mediastinitis, mostly in the non-post-op mediastinitis, but can also occur post-op too. So the diagnosis here would be clinical, and it's confirmed during surgery when pus is going to be noted in the mediastinum. So how would you treat that? You want to drain the pus with surgical debridement and an immediate closure with prolonged antibiotic therapy. Antibiotics alone are not going to appropriately treat the mediastinitis. You got to drain it and clean it. So the mortality is 10 to 50% even with appropriate treatment. And atrial fibrillation commonly occurs within the first few days after a CABG is done, and it's usually self-limited with resolution within 24 hours. Rate control with beta blockers or amiodarone is going to be the best, and anticoagulation with or without cardioversion is going to be reserved if that atrial fibrillation is going to persist, and that's usually more than 24 hours after you do a CABG. So moving on, we have pericardiotomy syndrome. Here, the patient presents with fever, leukocytosis, tachycardia, and chest pain. It's an autoimmune syndrome, and it occurs few weeks following the procedure with a pericardial incision. So you'd want to treat this with NSAIDs or steroids for inflammation, as well as pericardial puncture if tamponade occurs. Then you have post-pericardiotomy syndrome. So we just discussed pericardiotomy syndrome. Now this is post-pericardiotomy syndrome. This is a pleural pericardial disease and occurs days to months after that cardiac surgery or injury, versus pericardiotomy syndrome is a few weeks. So this one is up to months after the surgery. Inflammation from surgical intervention can lead to reactive pericarditis, pericardial effusion, or even a cardiac tamponade. Pleural effusions can also occur, leading to blunting of the costophrenic angles, and most children are going to develop small and self-limited pericardial effusions post-operatively. Infants with larger effusions, such as abdominal pain, vomiting, and decrease in appetite. In older children, it's usually going to present with pericardial friction rubs and pleuritic chest pain. And those can also present with cardiac tamponade with that Beck's triad, tachycardia and to maintain cardiac output, tachypnea and dyspnea when the cardiac output becomes compromised, and the treatment here again would be pericardiocentesis or pericardiotomy. Lastly, we have a retroperitoneal hematoma, and this is a history of recent cardiac catheterization, anticoagulation with sudden onset of hypotension, tachycardia. Flat neck veins and back pain are going to suggest a retroperitoneal hematoma, and that's due to bleeding from atrial or arterial access points. There can be local vascular complications at the cardiac catheter insertion site with a retroperitoneal hematoma, and that will then cause bleeding and localized bleeding or retroperitoneal extension, as well as arterial dissection, that's rare, as well as acute thrombosis and pseudoaneurysms or AV fistulas. Most hemorrhages or hematomas can occur within 12 hours of catheterization. Clinical features of a hematoma would be localized discomfort with swelling of the soft tissue, as well as if there's puncture sites above the inguinal ligament, a hematoma can extend into that retroperitoneal space, and even with minimal visible localization of the hematoma, that can suddenly cause hemodynamic instability, as well as ipsilateral flank or back pain. So the diagnosis here is confirmed with a non-contrast CT of the abdomen or the pelvis, or you can do an abdominal ultrasound. And you want to treat a retroperitoneal hematoma either supportive with intensive monitoring, bed rest, and IV fluids, or you can do a blood transfusion. But surgical repair of the hematoma or retroperitoneal hemorrhage is rarely going to be required. So how would you prevent a retroperitoneal hematoma? Well, with local hematomas, this is not uncommon. So the patient should be advised to avoid strenuous activity or lifting heavy objects 1 week post-catheterization. Radial artery approach is going to lead to fewer local vascular complications, and so that is why radial artery catheterization is going to be preferred. And that's the end of surgical cardiology. And now the final topic is OBGYN cardiology. So OCPs and hypertension is going to be the topic. So OCPs can cause hypertension, especially in patients with previous histories of hypertension in pregnancy and with a family history of hypertension. So there can be discontinuing the oral contraceptive can correct the hypertension in 2 to 12 months. In 5% of the cases, it can actually lead to an overt hypertension. So we want to inform the patient regarding the risk of continuing and the benefits of leaving the OCPs with alternative methods of contraception. If they do discontinue the oral contraceptives, but it does not correct it, then go for diet and exercise modifications. And that's helpful, especially if the patient is obese. If it still doesn't correct it, however, then you want to do a low-dose thiazide diuretic. So remember, first, if the patient's on an oral contraceptive and they have hypertension, take them off the oral contraceptives and give them on alternative method of contraception. If they keep at it with the hypertension, regardless of taking them off of OCPs, then you want to modify them with the diet and exercise. And if that doesn't work, then you give the thiazide diuretic. And the mechanism of OCPs and hypertension is that estrogen mediates an increase in hepatic angiotensinogen synthesis and the effects of the renin-angiotensin system. So that's why you get the hypertension with OCPs, that estrogen is going to stimulate the renin-angiotensin.